can see that the bipolar insert is comparatively fresh, clean insert. Hold, wait for the blood to stop flowing, and then you push the foot switch. And single application is sufficient. Don't try to make the whole red area black. It is what you learn after you know everything that counts. As far as bleeding is concerned, if you do not panic, if you are in control of the situation, if you understand how to stop the bleeders, you will never have any problem. Bleeding as such is not a problem. It is the effect of cautery which creates problems when you have the issues. Now, this is the next step, the bowel. So I have put in a trocar, and when you see mucus like this, that means you are inside the bowel. Patient of primary infertility, no previous surgery, no previous scar on the abdomen. I have put in the 10 mm trocar. While creating pneumoperitoneum also, there was a slight doubt of whether I'm in the right location or not. But because she was primary abdomen, we have put in a direct 10 mm. And then I see that I am inside the bowel. So we put a side port, take a look inside, understand where the adhesion is. I have not removed the trocar completely, just try to withdraw it till I get an entry. From the side port, we see that the entire midline, the bowel is adherent from xiphisternum to the pubic symphysis. Whatever peritonitis she must have had, adhesions can happen at any time. General dictum is if you have not entered into the bowel, you have not done enough laparoscopy. So sometime or the other, your trocar is going to go into the bowel. Do not be overly worried about it. Do the adhesiolysis and do the repair. If you are comfortable, do it yourself. Otherwise, you can ask a surgeon to come over and finish the repair for you. Adhesiolysis has been done and we have repaired that puncture point. The bowel was bloated, so I knew that it is only having an entry puncture. There is no exit wound. If the bowel would not have been bloated, then I would have to search for the entry as well as the exit wound separately. So in this case, patient went home quite comfortably on day 5. We usually wait for the flatus to pass on day 2 or day 3 and then start the patients with liquids and then solids. And then on usually 5th day, I'm comfortable in discharging these patients. The adhesiolysis which we did, we left a little bit of the abdominal rectus fat area along with the bowel so that it forms a sort of a cover in that raw area. No need to do a double layer closure. This was just a single layer closure which was done for this particular small entry wound. It's a 1 centimeter puncture. 1 or 2 simple stitches are enough. Now to prevent this kind of a problem, if we have a scar, I used to take the side port entry. The lower side port is the first blind entry after having created a pneumoperitoneum. We put in a scope from the lower side port, take a look inside, and then put in the 10 mm supraumbilically after finding a clear window inside. So this is the 10 mm coming in under vision once you have gone in with the side 5 mm port. This is called as a side port entry technique. So this allows you to probably avoid any punctures if there is a midline scar. And then this side port entry also has gone. You can see there is a bowel adhesion over here. And even the side port entry has gone through and through the small bowel. So it's like I said, if you have not put the trocar through the bowel, you have not done enough laparoscopies. So whatever entry technique you might be using, sometime or the other, this is expected to happen. It's part of the surgery. Deal with it. Make sure that you don't miss it and then repair it properly. So this is the exit wound being sutured right now. 2 simple stitches with 30, I think, or 40 Vicryl. Again, part of the surgical collection from the first 5 years of my laparoscopic surgery from 2002 to 2007. I have encountered everything in those initial 4 or 5 years. And then when you overcome your initial hurdles, your initial stumbles, that is when you become better and better with your surgical outcome. This I am doing further adhesiolysis. Now what is seen is the entry wound. So whenever you have a bowel injury, you have to be sure that you are not leaving any exit or entry wound aside or any puncture which you might have also created with the varies and ignoring it. Because in case you ignore this and the patient leaks on day 4, day 5, then comes with a peritonitis, then it becomes more troublesome to manage it. Identifying something as a primary injury on table is easy to diagnose. and equally easy to manage without any undue side effect or complication to the patient. Aren't there enough problems in the world already? So laparoscopy inherently, because of its own surgical technique, there are some problems which can come up when you are operating. And those things which may not come up if you're doing an open surgery, something like this. You have put in a varies from the side port, and the varies can sometimes hook up the mesocolon or the mesentery or the peritoneum. So this is just hooking it up. Generally, the varies will hit the bowel, slide along the bowel, where the mesentery is attached to the bowel and puncture in that particular point. So when you put in the scope, you see a lot of bubbles in the mesentery. Nothing to worry about, just ignore it. Again, this is one of my earlier hysterectomies. I am dissecting a small bleeder, venous bleeder. I'm going towards the uterus and coagulating, but the bowel has not been pushed back, and then you can see that the bowel was touching from behind. Now, I have not even realized at this particular stage. I'm just going towards the uterus, coagulating onto the side of the uterus. And then a little later, I realize that the bowel is white on the lower side. So when I use the cautery in the first part, that is when the bowel was touching the uterine tissue from the posterior side and the heat got transmitted. Corneal structures. I have coagulated the corneal structure stump, the corneal stump on the lateral pelvic wall. And then after having coagulated, I realized that the grasper here is lifting up a small part of the bowel mesentery. But fortunately, bowel was not touching it. It was not cauterizing. So you have to be careful with your movements. Inadvertent part of surgery is something different. Like trocar going through the bowel is part of surgery because the bowel is already adherent. You cannot avoid it. Whatever technique you use as an entry technique, sometime or the other, it can happen. It's part of surgery. But when you are using your instrument and cauterizing the tissues, this should not happen, that you are now lifting the mesentery or the bowel accidentally in the instrument. So this is something which you need to be careful about and definitely need to uh, prevent from happening. A small uterus, sort of post perimenopausal uterus, and we are doing a hysterectomy, previous cesarean patient, traction given with myoma screw slips, and it has hooked up, fortunately, the mesentery, not the bowel. So this is also an accidental trauma which should not happen. The myoma screw should be in control, even though the traction is good. And there are times that the myoma screw is likely to lacerate and tear through the tissues, because if the uterus is soft or friable, it can happen. Or if the fibroid is too hard and not coming out of the uterus, there are times when you have to exert a significant force on the myoma screw to get the fibroid to cooperate and come out of the uterus. The incision here is also not very small, but probably because of previous earlier surgery, there is some fibrous tissue, and that is why the fibroid is not popping out and the myoma screw broke. Fortunately, it broke because it hit the external iliac, but the blunt instrument hitting the iliac was okay. If it would have caused a laceration there, then that would have become a significant problem. Early cases of morcellation, when we were using the Gynicare morcellator, I'm morcellating and now I'm trying to manipulate the uterus with the morcellator itself. So I have lifted the morcellator blade. The blade is protruding out. Though I have not pushed the foot switch, the blade is still protruding out, and it has hit the upper part where the upper dome of the bladder is seen. And then when you try to visualize it, it suddenly oozes. But like I mentioned in the beginning of the lecture, if it is a venous ooze, you let it bleed, maybe after 100 ml, it will stop oozing. This one we have not cauterized, and after having some initial ooze, it stopped on its own. Because if I would have cauterized, I would have been worried whether it has gone close to the um, bladder. Again, a similar morcellator accident. Fortunately, it has cut on the uterus and not on the bowel. Good judgment requires experience, and this experience comes out of bad judgment. So complications are part of surgery. It is not something which is never going to happen. The third part is the bladder part. So one of my very first fistulas, a small bleeder, and I have cauterized again, I have cauterized once more, and I have cauterized once more. The amount of cautery which I have used was phenomenal. Invariably, the patient came back with a fistula. So if you are having a problem in any patient and you go back and you see your video, it becomes very easy to identify. This is a fistula inside the bladder. This is a ureteric opening. And it really shakes your confidence. You can see the hand shaking over here. But again, like I was saying, it really helps if you have your videos recorded and you go back to your initial surgeries and you see the video, then that is the time when you realize that most of the times the complications have happened by something which could have been avoided. And that is how you learn from your own mistakes. It's always easier and better to learn from somebody else's mistakes, but there are times when you eventually have to learn from your own mistakes. No matter whether you are having an HD camera or a 3-chip HD camera or a 3D camera, till you have a fistula, you will not have a clear vision of where the bladder is. So this is, I think this should be sufficient for the lecture. Is this all right? I do have more videos, but this should be sufficient. Complications are something which you can collect. The more complications, the more number of years you have, the more complications you invariably get, and there is never an end to it.
Yeah, but I think it was wonderful. You took us through some very important aspects, where to avoid, how to avoid. And I think you took us through your initial years where most of the complications do happen. And I think it will be very useful for others to see and learn, and especially the part where the bowel was picked up, how to look behind. And also it helps if you have a very attentive, say, nurse or an assistant who's looking at all these things. So it's the job of the assistant to help you that such things do not happen, I think also. So, I mean, surgeon has to be alert, I'm sure, but some of these things could be avoided if you have a very attentive and helpful assistant as well.
Can I request the tech team to unpin my video, please?
Pardon?
No, my video has been pinned. Yeah, now this is okay.
Okay. Fine. So I think it was a wonderful talk. I think in interest of time, we should move on. But I think we can take a couple of questions. Are there any questions?
No, ma'am. No, ma'am. Right now, there are no questions in the chat box.
Very interesting, Dr. Rajesh Modi.
Thank you, Dr. Rekha and Dr. Bijoy Nayak for being there as chairpersons. And again, thanks to Bhaskar for being a wonderful friend throughout the journey which I've had in Gynac, and being such a welcoming person at any stage of time.
No, I think Rajesh is one of the best teachers I've come.
Yes.
I think we have plenty of brilliant endoscopic surgeons, but I think Rajesh's surgeries, when you see, you think, yes, I can go and try it, because it simplifies it to that extent. And also it's to the ability to analyze his complications and give people take-home messages that what they should and should not be doing is brilliant. So it's one of the best teachers for youngsters to have around.
Thank you.
Yes.
Thank you so much to the chairpersons.
Yeah.
Thank you
on
so
behalf of Dr. Bijay Patnaik and myself, we want to thank Dr. Bhaskar Pal and the whole team for having included us in this, and all the best to the presidential elections.
Yes, all the best. All the best.
Thank you so much, respected chairpersons. Thank you so much, Dr. Rajesh Modi sir and Dr. Pandit Palaskar sir, for those wonderful lectures. We now move on to the second session. We have 4 eminent speakers in the field of endoscopy. Again, Dr. Bhaskar Pal, Dr. Abhishek Chandravarkar, Dr. Manoranjan Mahapatra, and Dr. Sandesh Khade. And to chair this session, we have 2 eminent endoscopists. Our first chairperson this evening is Dr. Mehul Sukhadia sir. Admin, may I have his CV, please? Dr. Mehul Sukhadia is the member of Gujarat State ART and Surrogacy Regulation Act. He's the director of Sumiran Women's Hospital and IVF Center, Ahmedabad. Sir has a vast experience in IVF and laparoscopy of over 25 years. He has trained more than 950 doctors from India and out of the country. He has the credit of doing a bloodless TLH in 25 to 35 minutes. He has published the atlas called Gold Standard Techniques of TLH, and he's a invited faculty in various national, international workshops and conferences. We welcome you, sir.
Thank you. Thank you so much for your kind words.
Our second chairperson this evening is Dr. Suman Puri Madam, who's the professor and head of Obs and Gynae, Unit 2 at Dayanand Medical College and Hospital, Ludhiana, Punjab. Ma'am has been the vice president of IIG Punjab chapter. She has more than 25 years of experience in clinical practice. She has pursued reproductive endocrinology, infertility, advanced laparoscopy at Mount Elizabeth Hospital, Singapore. She's the coordinator for the FOXI affiliated laparoscopic training program and co-principal investigator on Indo-Danish project on gestational diabetes. She has various publications at national and international levels, and she has been the organizing secretary for MRCOG program at DMCH. We welcome you, madam. So I would like to hand over the proceedings of the next session to the chairpersons, and I would like to help them to introduce our first speaker. Our first speaker will be Dr. Bhaskar Pal, sir. Requesting the chairpersons to please introduce, sir.
So thank you so much. Can you hear me? Thank
Yes,
you
ma'am.
so much. Okay. Thank you so much. It is in fact a great honor and pleasure to be the chair in this session. And by none other than our dear sir, Dr. Bhaskar sir. In fact, you've just put a CV in front of me, but I think Dr. Bhaskar here needs no introduction to any one of us. And we know him so well. He's the most dynamic, most energetic, and extremely fair to everyone leader that we know. And we are looking forward to seeing him in his new role as the leader and the president of FOXI. And we'll be waiting to start his talk on tissue retrievals in endoscopy, which is a very important topic because it's very easy to remove a TO mass or a myoma, but the challenge lies in as to how to take it out by an endobag or through the POD. So looking forward to your talk, sir, and all the best, sir.
Thank you. Can I share my screen, please? Can you stop sharing, please, admin? Himanshu, please stop sharing the screen. Yeah. Is my screen visible?
Yes, sir.
Okay, I'll be speaking on tissue retrieval at laparoscopy. And when we talk of tissue retrieval at laparoscopy, we talk of ectopic pregnancy, we talk of adnexal masses, we talk of fibroids at myomectomy, and we talk of uterus at the total laparoscopic hysterectomy. Now, if it is an ectopic or a small cyst, it's easy. The first thing that we try to do is try to railroad the specimen into the 10 mm port and take it out through there. The other option is if railroading is difficult, then we put a 5 mm scope through one of the side ports and then use a grasper, 10 mm grasper through the 10 mm port and pull it out through the 10 mm port. Sometimes an adnexal mass, which is a little broad, it might need to be fashioned into a longitudinal strip so that we can easily take it out through the 10 mm. These are not the problems. The problems are with large masses. The large masses, one option is to remove in endobag. But this is not a question of taking out in endobag. This is a very, very large mass. And as you can see that this is twisted. And sometimes with very large dermoid, you attempt to do it laparoscopically, you have to accept that some amount of spillage would happen because you will have to decompress the cyst to some extent. Now, this is a cyst which is torsion, but in spite of the torsion, there are areas where we can see healthy ovary. So what we do is we untwisted the cyst, then we decompressing the cyst. And this is what we are talking about, that although this is a large cyst, we are trying to cut it into a longitudinal strip, make it a long vertical piece so that we can easily take it out through the 10 mm port. So avoid using a bag, which of course is expensive, and then we can take the specimen out like this. Now, sometimes we need to be innovative and we need to do something different. And so we will look at different options of tissue retrieval. So here you can see this was reported as a mesenteric cyst, turned out to be a large ovarian cyst, which are twisted from an otherwise looking healthy ovary. So this is a large one. So we decided to put it in a bag. This is not an endo bag. It is any of the, you can take the bag of the classic grape or something, and then you can put the tissue in there. And if necessary, you can, then you take the port out through one of the side ports. And that is a little bit of a debate whether you should be taking it out from the lower side port or from the upper side port. If you widen the lower side port and take it out cosmetically, this is better. But the patient will have more pain because that is a port which every time she moves, there will be movement in that. So once you close the nectar sheath, that is going to have a little bit of more pain. If you take it out through one of the left upper port, then the patient will have less pain in spite of you suturing the nectar separately. But cosmetically, you'll have a 1 centimeter scar. So this is the way that you will take this out in this case. Now, this is again what we talk of thinking a little differently at that point of time. This is a postmenopausal patient. We had a large ovarian mass, so we decided to do a laparoscopic hysterectomy, but we didn't want to have a spillage in any way. And so what we did was we put a Morsafe bag through the vagina. That is, I'll come talk about the Morsafe bag a little more later. And then we put the large mass inside the Morsafe bag. And then the open end of the Morsafe bag, we'll push it through the vagina and then close off the sleeve end of the Morsafe bag so that no spillage happens from there as well. So we push this into the vagina, and then from the vagina inside the bag, we'll gradually cut this mass open and take tissues out. This turned out to be a very, very large dermoid cyst with varying type of contents. You can see that we are closing off the sleeve end so that nothing can spill out of that. So in case, because she's a postmenopausal patient, something comes out to be malignancy, we will not be worried. So after everything is done, then we take it out from there. Now, how do we remove an uterus at TLH? At one point of time, a large uteri, what we used to do, we used to morcellate them a lot. And we used to morcellate them. We could morcellate the whole thing, or we could morcellate part of the uterus to make it into a longitudinal mass and then remove it vaginally. Now, there's a lot of debate whether you should do a naked morcellation. I think that is why we prefer to remove almost all uteri at laparoscopic hysterectomy through the vagina. And if it is a large uterus, it might need a vaginal bisection or morcellation or a coring technique. Now, this video is from my friend, Dr. Abhinesh Chatterjee. And this is what one of my friends calls it the pineapple technique, very much like your roadside vendor cuts the pineapple. So you use a claw forceps to hold the cervix, and then you pull it to one end, and from the other end, you make a cut, and then you twist the uterus and move it to the other end, hold it again, twist it to the other end, and then cut from the other end. So gradually what is happening, you are converting the uterus into a long cylindrical tissue. That is what is going to happen. And just like the skin of the pineapple is taken out, as you see, that as the vendor keeps cutting the pineapple and rotating it, he gradually moves upwards. And here is also we're doing the same thing. We are cutting a little bit of the uterus, rotating it, and then on the other side, going a little upwards. Our chairperson, the first time I saw this being done was many, many years back, but our chairperson of the previous session, Dr. Rekha Kurian, who took it out beautifully. And I think laparoscopy has made many of us better vaginal surgeons. In pre-laparoscopic days, we wouldn't dream of taking a uterus like this vaginally. But these days, I think we've got used to this. So as you continue doing this, as you can see that the uterus is gradually coming out as a longitudinal strip. So at the end, it is very much like if you can do a morcellation laparoscopically, how you can take a long, thin morcellated strip. You do not need to have that thin, but something that can come out through the vagina. So you need this claw forceps. every time you cut, you hold with that and you rotate it, and which means you go to the other side and you go a little bit higher up. So if you can take a look at that entire specimen, this is a 20-week size uterus, and you can see the whole specimen has come out like a long strip. And that is how we should be removing large uteri at that. These are the two instruments you need for that. You need a claw forceps and you need a cat's paw forceps, and you need this knife which is got a long handle and a heavy handle. Now, myoma, I think I'm very much against naked morcellation, and not only this is for the risk of leiomyosarcoma, it is more because of the risk of disseminated leiomyomatosis. When we go back after a laparoscopic myomectomy where we've done a naked morcellation, if we go back with a laparoscope later on for any reason, we usually see these myomas which are everywhere on the abdomen. So that is why we should be doing a contained morcellation in a bag. The other option is that you can do a colpotomy and take the fibroid out, or you can remove them through the endometrial cavity into the vagina if you open the cavity, or of course you can do a mini laparotomy and take the myoma out. This is how we morcellate. This is the bag which we put inside the abdomen. And what happens is that this is a bag which is shaped like a stomach called the morcep bag. So two ends of the bag will remain from this large end, where we put the tissue and then take the large end, you close it and take it out through one of the side ports. Again, the same debate about whether it should be the lower side port or the upper side port. We take it through the lower side port. And from there, you will put in your morcellate. We will show what you do with your other end. This other end is like the esophagus, and you railroad it through your camera port, and then you put your camera inside. So you will now be operating in a stomach-shaped bag in which you have two instruments. You have your laparoscope with your trocar, and that will inflate into the bag, and the pneumoperitoneum will be created in there. And from the other side, your morcellator has gone. So this is the bag which separates the entire abdominal contents and the intestine. And you are going to gradually morcellate, and everything will be contained. Whatever small pieces fly out and remain, that will happen inside the bag. So this is a bag which is available. It is a little expensive when you talk of MRP, but if you buy it directly from the company in bulk, it works out cheap and you can pass that benefit to the patient. And so morcellation becomes easy. Not only you cannot accidentally go and injure another organ with your morcellator. Again, if there is no risk of leiomyomatosis, number one, and of course, in the rare odd case, if there is a leiomyosarcoma, you will not be upstaging the disease. So everything is happening inside this morcep bag. So that is how we go about it. I think this is another short video of using the morcep bag. You can see again, same story. Inside the bag, we are morcellating. And so the myoma stays inside the bag. From the left-hand side, your morcellator is going in, and from the central port, your camera is going in inside the bag with the gas going inside the abdomen. And at the end, when you are taking out the bag, make sure that you've taken out the camera and you close that end off with the suture so that no tissue falls out from that, and you pull out the bag from your left side port. Again, whether it is lower or whether it is upper, it doesn't make a difference. Now, this is how the morcep bag looks, and we need to make sure that in the abdomen, the bag doesn't turn. With experience, you achieve that easily. So you need to make sure that your positioning of the bag is correct. Otherwise, what will happen is bag will twist inside the peritoneal cavity, and you will not be able to get the pneumoperitoneum inside the bag the way you want to. And this is how you put the bag. You fold this bag, and it comes in a small inserter, which you put through your left 10 mm port, and then you pull that into it. This is a short video describing that. So this is the open end of the bag. This is where the specimen would go. You'll put it in the abdomen. You put the specimen in there, and then you will pull this edge out to the left-sided port. And that is what is because it's got a rim like in a glove. And this is how you put it. You fold the bag and you put it into that inserter that comes with the bag. It can be reused. We do a sterilization and we reuse the bag. And then what happens is that there is a tip in that bag through which you put it into the 10 mm port. So this you put it into the 10 mm port, and using your internal instrument, you pull the bag in, and you only with your left hand, you pull this inserter out. And then, as I said, that the tissue would go in here. Now, this is the other way of removing it, and that is through the pouch of Douglas. So this video is a little dark, but what you can do is you can put a swab on a stick on the through the vagina to elevate the pouch of Douglas in between the two uterosacral ligaments. We are using a monopolar cutting current. With that, once you see the gauze, you've got it open, and through there you can take the fibroid out. And then some people actually keep the pouch of Douglas incision open. We like to suture it, and you can suture it with 1 or 2 interrupted sutures depending on the size of the defect. And this is a very cheap way of removing your fibroid, so that you do not need a morcellator. You save on the cost of the morcellator as well as the morsafe bag. So this is one way of taking fibroids out, especially if there are multiple small fibroids, you can take it out. If one fibroid is not too large, that is how you can take out. Now, again, there are other ways of doing it. Now, this is a lady who had plenty of fibroids, multiple fibroids, and we ended up opening the cavity because there are multiple submucous fibroids. And then what we did was we saw that some of the fibroids, we could actually push it into the endometrial cavity, because when there is a large submucous fibroid, the os would be dilated. So we saw some of the submucous fibroids, we could push them into the vagina, to the endometrial cavity, and that is what we did. And whatever was left with, then you can either morcellate that, or you can take it out through the pouch of Douglas. Saves you a little bit of time. So this was a very much on-the-spot decision to remove it like that. So you can see that's a small fibroid, and we put it into the vagina. Similarly, all the fibroids that are there, we will try and see how many of them we can push them to the vagina. This is a calcified fibroid. Let's see whether it goes or not. If it goes, we will not going to struggle. Otherwise, we'll take it out and we will remove it through the pouch of Douglas, or we will remove it through the by morcellation. Similarly, there's another smaller fibroid that also we should be able to put it through the cavity. So there are ways to do that. And that is it for me. And again, I look forward to your vote and support for the post of Foxy President. Thank you very much.
Thank you, sir. That was really nice, and all the videos were very informative. In fact, taking it out through the pouch of Douglas really shortens the time, because the morcellation would probably not be needed in those cases. So, and especially for dermoids where we don't want any spill, I think putting it in a bag and taking it out is a good option. So thank you, sir. That was really beautiful and very good videos we could see. Should we go on to the next speaker, sir?
Yes, yes, madam. Yes, madam.
Okay. So next, I would like to invite Dr. Abhishek, who's going to talk about uterine artery ligation at origin. And Dr. Abhishek is associate professor at D.Y. Patil Medical College and director and consultant of the Apeksha Maternity and Nursing Home. And he's a managing council member of IAGE and founder treasurer of MEG and the treasurer of TOGS 2018-19. We welcome you, Dr. Abhishek, and looking forward to listening to your talk.
Good morning to everybody. At the outset, I would like to thank Dr. Bhaskar Pal for giving me this opportunity. I'm Dr. Abhishek Mohan Chandavkar. I will be speaking on retroperitoneal approach in laparoscopic surgery. Now, it's the new kid on the block, or probably I can say that it was the new kid on the block, because everybody seems to be doing it now. But this is what I'm presenting is for somebody who wants to start off doing retroperitoneal surgeries. Primarily should have a good vision, that is a good optics in terms of good camera and scope, great exposure, good assistance. So retroperitoneal or any surgery which is more difficult cannot be without good assistance and a good energy source. So the techniques of dissection, before I go to the video, is just to understand how you can go about it, and then we'll see the same in the video. So we have a good stretch on the infundibulor pelvic ligament and lift the peritoneum in the triangle. The triangle is between the infundibulor pelvic ligament, the round ligament, and the lateral pelvic wall. Make an incision parallel to the infundibulor pelvic ligament on the peritoneum. Reach the pelvic wall laterally. Sharp dissection on transverse fibers. Identify the ureter as it crosses the iliacs, and identify the external iliac artery and the vein. A blunt dissection to be done between the ureter and the external iliac vein, and that is how you can identify the uterine artery, which is the first structure crossing from lateral to medial. This is more so because this would be the primary start of where you would do a retroperitoneal dissection, where you would identify the uterine artery. Once you can identify all the structures, automatically you can advance your retroperitoneal dissection to lymph node dissection and further down into the pelvis. The uterine artery identification is a tortuous vessel with a bluish hue. It origins from the internal iliac, and as it continues as the obliterated hypogastric and crosses over the ureter. So just having a look at the video, like I said, the triangle between the round ligament, the pelvic side wall, and the infundibulor pelvic ligament. Make an incision and then extend the incision parallel to the infundibular pelvic ligament. Extend it adequately so that on both sides, so that the dissection becomes easier and the exposure becomes easier. So the dissection techniques, you can use the ultrasonic energy, you can use a bipolar cutter, you can use bipolar with scissors. As long as you have a clear field, it doesn't matter what your energy sources you're using. Now, when you're taking the transverse fibers, don't do blunt dissection, as you'll end up with a small amount of bleeding there, which can be controlled. So a sharp dissection at the transverse fibers ensures that you have no bleeding when you're dissecting. The blood during this kind of dissection will completely obliterate the visual field and cause trouble for your further dissection. Then the next part is creating blunt dissection. The point where would be dissect directly medial to the external iliac vein rather than dissecting more on the medial side, because if you dissect more on the medial side, we'll create a window in the broad ligament. So that is the external iliac artery and the external iliac vein just below that. Keep on dissecting parallel to it, and once you dissect parallel to it, you can identify that is the obliterated hypogastric, which is the continuation of the internal iliac artery. Now, once that is identified, the ureter is easiest identified when it's crossing over from the, this is the obliterated hypogastric. That is one way of identifying the internal iliac. Once you hold the obliterated hypogastric and you pull on it, you can see it moving over here. And then you can go from anterior and go back towards the internal iliac and identify that. This is just for an understanding of the anatomy. The right common iliac separately bifurcates as the external and internal iliac, and the ureter crossing over here. Once you identify, the ureter is most easily identified at this level. So once this is identified, you need not always identify it without the dissection. It can be easily identified even at this point, just by dissecting further medial to the external iliac vein. There you can identify the ureter going in, and once you dissect, keep dissecting further in, you can see that it is, you can identify the ureter. Once the ureter is identified, between the ureter and the external iliac vein, once you keep dissecting, the only structure which crosses, first structure which crosses lateral to medial is the external, is the uterine artery. Now, why we dissect the uterine artery? Because most of the time, this is what you would use in your initial stages of your retroperitoneal dissection. So that is the internal iliac artery, and that is the uterine artery, and that is the ureter over here. Now, this is just to show that there's another technique, the posterior approach for accessing the uterine artery. This is a medial to the infundibulum pelvic ligament. A small window is created just between the isthmus and the infundibulum pelvic ligament. And there, as you make it just above the level of the ureter, you can identify the ureter. And when you dissect the ureter, just lateral to the ureter, there you can identify that is the uterine artery. This is a little more advanced technique because you should know exactly where to dissect it. Otherwise, the lateral window technique is the easiest to access. Once you know your anatomy well, even the posterior window will help you identify the uterine by just minimal dissection. But this is not always easy when you're starting off. So the lateral window technique should also be known before you continue with your posterior window technique. So in case you have bleeding during your dissection, what can we do? First and foremost, just hold the vessel. Give a very small energy burst, ensuring that your ureter is nowhere close by. Because if you have your ureter close by, you should not have the lateral spread going to touch it. Then suction out all the blood that is there. Do not irrigate. The irrigation causes more flooding of the tissues and it causes more, decreases your vision further. Use of an RO gauze is something which is very good. You can keep a RO gauze in and use it immediately to wipe the area or just dab the area, and that itself will be. But the important part is to use it only a RO gauze so that, and also to remove it because that is the only thing which can be left back. And then the other technique is to dissect further. Whenever you have a blood stained area, just dissect a little further deeper into the tissue and you will get a virgin plane again. And these are the small tricks. If you have too many of oozers on one side, just stop there, go to the opposite side, finish the opposite side, and then come back. By the time that bleeder would have coagulated, and then you can continue. And if you're starting off and you're finding it a little difficult, this is vasopressin. Obviously, you cannot use it primarily only for this thing. If you're using it for a myomectomy or something, you can use it and then go ahead with the dissection. Now, what is the need for doing retroperitoneal dissection other than using it for endometriosis or for major oncosurgery? Thing is, to start off, you can use it in cases where vasopressin is contraindicated, like in myomectomies. Now, in a large fibroid where vasopressin is contraindicated, it may help to use the uterine artery at source. Then the next need would be to do in multiple myomas. In this case, you can see that there are multiple myomas. It does help. You can do the surgery only by just doing a bit of vasopressin at each stage and then removing myoma by myoma and suturing it. The advantage of doing the uterine artery at source in these cases is that you have a longer time period where you can do multiple myomas can be dissected at a single setting, and you can go ahead with removing, before you start suturing the beds, you may remove more myomas in a single sitting. So the technique remains the same. Here what one can do is just ligate it, because if the patient is requiring fertility, just ligating it also can help. It's not necessary. Even they say that even if you do the shoelace technique is a good technique which you can do, and then you can go ahead with removal of the fibroids. Then the next thing would be an unusual location of the myoma. So you have a very cervical myoma which is present and you have no access to it. In those cases, a uterine artery dissection and ligation or coagulation bilaterally would be of use. And then you have very large myomas in which you can probably use it for the uterine artery, can be used to be ligated and all. But that is all primarily to understand how your technique to dissect the retroperitoneum rather than doing it in cases where you would not be able to do it. Then the need is to think out of the box when you have to do a uterine artery. In this case, the patient was A negative or had a negative blood group, and the blood which was available was just a single blood. Her hemoglobin was just 10. So just to make sure that to be on the safer side, we were going to use vasopressin, but an additional help so that the bleeding is further reduced. That was done. Shoelace knot. And then the controversy, whether it's required in a TLH, retroperitoneal dissection. My personal opinion is you really don't require in a TLH to do retroperitoneal dissection, is because here what you can see is actually I'm not doing retroperitoneal dissection. I am just dissecting it near the isthmus, dissecting the uterine artery near the isthmus itself, and there you can see that the ureter is going just below the uterine artery. So in this case, you can actually see I've dissected the uterine artery even without dissecting the uterine retroperitoneum. So my personal opinion is doing retroperitoneal dissection in a uterine artery ligation in a TLX is absolutely very not required. Maybe very rare case you might really require it, but it's not routinely required. The advantages, like I already mentioned, is reduced blood loss and increases the operative time window. And the pitfalls, always love the slide where it says that there were some complications because it looked way easier on YouTube. So I hope it never happens to any one of us. And this is a video which I borrowed from Dr. Abhishek Mangeshikar. His friend lent it to him, and his friend is here doing, in a routine case of a TLH, doing a dissection, retroperitoneal dissection, and he's dissected what he believes is the uterine artery. And now what he does is nicely ligates the uterine artery there. And while he's ligating, can you see the peristalsis over there? He's effectively ligated the ureter. That was identified and it was taken care of. But in a case of TLH, basically an unindicated case, unnecessarily you landed up in a soup. So never ever do something which is unindicated. So genius sometimes consists of knowing when to stop, and that is the most important thing. So stay safe. Use skill associates. See, you should have skilled associates. Should have very good friends who can help you out, urologists, oncosurgeons, whoever, vascular surgeons, to help you out in any point of time. And primum non nocere is always do no harm, because even the best of batsmen never go out unprotected. So thank you.
Thank you, Dr. Abhishek. That was very interesting. In fact, they were very good tips for all the newcomers, and definitely we really don't need to ligate the uterine artery at origin when you're doing a case of total laparoscopic hysterectomy. And in fact, when we teach the residents, we have started identifying the ureter in all our cases, so they are very confident whenever they are doing all the steps, because when you know where the ureter is and you're not damaging the ureter, when you know its exact anatomy, your confidence level really goes up. So every case we identify that this is the ureter and this is where it's going. And you had shown some very good videos, and they were very good tips and tricks for all the newcomers to start with. Thank you so much. And I would like to invite my co-chairperson if there are any comments.
Just one second. Hello?
Yeah,
I'm
yeah.
Dr. Abhishek. Yeah. So I'd first of all like to thank Dr. Bhaskar for inviting me for this and actually insisting me more. And I wish him the best of luck for all of those who have not yet voted. Please go ahead, and I think he's truly deserving a candidate. So please give our best wishes to Dr. Bhaskar. Thank you, sir.
But and Abhishek, thank you for joining. Abhishek is traveling, and in spite of that, I insisted that every time he's a very busy person and he has some excuse or the other for not joining. But today I forced him to.
No, I wouldn't excuse you, sir. I have no excuses. I have to come for you. So yeah, definitely, sir. Thank you so much.
So I would like to thank Dr. Bhaskar Pal for inviting me, and I will give him a good luck for his election proxy. So Dr. Bhaskar Pal is my one of the best friend in endoscopy. So he has delivered a very well lecture, and also Abhishek narrated well uterine artery ligation. But sometimes what happens when there is a bigger mass, when we actually need the uterine artery ligation, sometimes may not be possible. And in smaller cases, we can do. So as per the case and conveniency, he has demonstrated so many cases very well. So thank you, Dr. Bhaskar Pal, and thank you, Abhishek, for a wonderful.
And Dr. Mehul, he said that the posterior approach requires more skill. And if it's a big mass, the lateral approach becomes impossible. You have to take the posterior approach, and that makes it a little more tricky.
Yeah.
Right. Exactly, sir. Right. Dr. Mehul, you can introduce the next two speakers, I think.
Yes.
Dr. Poonam, I'm Dr. Usha M. Kumar here. Can I add on one comment here? Can you hear me?
Yes, ma'am. Yes.
Yeah, I just wanted to add one comment for Dr. Bhaskar Paul's talk, and it's very nice talk he has given. Just for the sake of the audience, I just would like to add one thing. Most of the time, we are manipulating this port for the tissue extraction, and we forget to put the port closer. So the very, very important tip is we have to put the port closer, because I have seen we are manipulating too much and we widen up that port. So if we don't close it, there is a possibility of bowel to get strangulated, and the patient will present to us with the subacute intestinal obstruction on third and fourth day.
Dr. Usha, in my early days in UK, I have had a patient who came in with intestinal obstruction on day 3. So absolutely on the lateral side, any port which is 7 millimeter or more, the rectus sheath has to be closed separately. I think that's a very important takeaway. That is what I said, that because it has to be closed separately, and that is why I think the most pain is because of the rectus sheath stitch. And that is why, although because of cosmetic reasons, I take it from the lower lateral port, the patients keep on complaining for pain for at least 3-4 weeks. And that is why I've seen many endoscopic surgeons using the morcellator through the left upper port. Because that port, that muscle doesn't move much when you are moving or walking. So the patient complains of this pain. So wherever you take it out from, it is obvious you have to put 2 stitches, and not only 10, anything beyond 7 on the if it's not in the midline.
Totally agree. We always do port closure when we increase the incision and we have to take out big masses, and we are using the upper left port normally, because probably, as sir is saying, the pain factor is quite less. So that port closer needle we use, and the stitch is taken out and the rectus sheath tied, and then we put the upper stitches. And that is what is taught to all the residents, that once you are increasing the incision, you have to do a port closer. Dr. Mehul, we can introduce the next speaker. I think you can go ahead with that.
So may I invite our next speaker, Dr. Manoranjan Mahapatra. So we know him very well. He is one of the well-known personality in laparoscopy. So may I invite him for his talk in ovarian mass obsession to opportunity. So please, Dr. Manoranjan Mahapatra, please carry on.
Please allow me to share the screen. Okay, thank you, Dr. Mehul. Am I audible?
Yes, you are audible.
At the outset, I must thank to Dr. Bhaskar Pal for inviting me, and all the best for his venture. And I really congratulate in advance for the presidency of the Foxy. And he is most deserving candidate around, and he should get the chair. And this is the best wishes I convey from the Odisha. And to the convener, Dr. Bhaskar Pal, giving the opportunity, and thanks from the heart. As my topic is laparoscopy in post-menopausal ovarian mass, it was adnexal mass, but I have confined my talk to the ovarian mass, particularly in the menopausal lady. I being a laparoscopist and also the oncologist, being in the teaching institute of the oncology, RCC. So I see both the spectrum of the situations, cases done laparoscopically reported to us in the OPD, and also as in laparoscopy day and out we face different situations to tackle the ovarian mass. That's why I chosen the topic to present before you this gathering. And the concept is that what are the opportunities and what will be the obsession if we'll cross the landmark. The video is in the recorded the video format. So I'll be just through the video, all the content is in the video format. So, ladies and gentlemen, the topic is laparoscopy in postmenopausal ovarian mass. Knowingly, I have brought the opportunity component first, then the obsession component to the later on. So, the talk, as I have told, is the video format. This is a nice video, but the passion and compassion has to be in balance. As you know, the ovary has three basic components. One is epithelium, the stroma, and the germ cells. The epithelium being the predominant structure that you find the mitosis. And ovarian mass can be benign, borderline, and malignant, but these are not the simple cases. Every case is a new and unique one. And the planning and procedure has to be very stringent. Mostly the planning component. And an adnexal mass has to be the symptoms, signs, sonography, serum markers, and the SOS surgery. So in the SOS surgery, deal up and proceed all these things. There are stringent criteria like the IOTA criteria, the ORADs, and there are the RMIs, the RMI guided situations are there. And to do laparoscopy, there are stringent guidelines are also there. You need to assist with the inceptor. In presenting some of the cases, this was a case, menopausal lady was detected with the ovarian cyst in the routine checkup, and she insisted that doctor, you remove my cyst and everything. And we went for, in this cases, we create the broad ligament window, we finish up the hysterectomy, and tissue retrieval is the most important thing that we should ventilate, that there should not be any spillage, even though it's a silent, simple cyst while the sonography and everything, we should take out. This is another case, a simple cyst, a menopausal lady. We are fortunate to get a ecogenic shadow suggesting for the dormant cyst. Again, we went for the opportunity and went for the hysterectomy. Again, the broad ligament window and finish up the hysterectomy, and lastly tackling the adnexa, and then it has to be taken out the same way. The puncturing the cyst, the content should be to the out, so that even if there is possibility of some malignancy, there should not be any spillage and upstaging the malignancy. That's the whole concept that I have to build. That was the dermoid, and the things, everything was taken out. There is not a single drop of the spillage inside the cavity, and there was the mass, the cut section. Always look into the cut section whenever dealing an ovarian cyst, and the mass was in the top. This was the case with post hysterectomy presented to us bilateral adnexal mass, and that come out with the bilateral hydrosulfates. This was another case post hysterectomy with ovarian mass, and in these are the cases they used to have a lot of adhesions. Must have enough anatomy to tackle such cases, and that was taken out and come out. That was another case of menopausal lady with ovarian mass, solid ovarian mass, and that was taken the laparoscopy, and it come out to be the fibroma of the ovary. These are some of the opportunities that I am presenting. That this with the so this was the case with pain abdomen, and we went for the laparoscopy. That was one side ovary was enlarged. That was also suspicious, and then another side was there was torsion, and the biopsy came out of the struma ovary, and there was some of the endometrial tissue. This was the case with the large ovarian mass with some of the solid components around, and I went for the laparotomy for this case. that some solid components are there, and she was 50 years, and there was definitely the cut section was also some suspicious was there, but fortunately it came out to be the benign. Some of the cases can happen, something like that. And this was another case with the CT scan very suggestive that there was some exophytic masses in the ovary. Our plan is to go for the diagnostic laparoscopy and SOS surgery. The counseling was accordingly and proceeded for the full malignancy surgery there and done, and full scale of the malignancy surgery was done. So for this case, the message that we must discuss with the patient that on table, if possible, we will proceed with the surgery for the malignancy. And of course, the frozen biopsy was sent. And always look into the specimen, always take photograph of the specimen, because that will help afterwards when you analyze the case with the XP report. So this was the cut section, which obviously shows, and the biopsy come out to the papillary mucilus cystadenocarcinoma of the ovary. So this was another menopausal lady with right side solid ovarian mass with some of the hypoechoic area, and there is hyperechoic the hyperplastic endometrium, which was proliferative, and we went for the diagnostic laparoscopy and peritoneal biopsy was done. And serum inhibin was high, so that we are confident that we are dealing a case of granulosa cell tumor. There again, we find the opportunity to proceed, and we took out everything. And here we took out the, then we took out the mass by loading into the urobag. So this is the urobag, indigenous urobag made, and we don't use the commercial bag because those are thin bags. There is chance of perforation. So that come out of the adult granulosa cell tumor. This was the full scale surgery. This is how we take out the urobag through the vagina. This is the mouth of the urobag. And if we have mutilation with the urobag, there is no violation to the malignancy because we are not spilling anything inside the abdominal cavity. So we are even cutting the tissue, making it piecemeal, and we are taking everything without any spillage. So this is the urobag and the mass. This is how we prepare the underbag. We cut the urobag upper part, then the bursting suture through the vicryl, and always include both the sides of the urobag so that will provide the strength. The bursting suture we take because after loading the tissue, we will drag the suture so that the mouth of the bag will be closed. And we can take out the suture first so that it will come to the pelvis. Then we can take out the mouth of the urobag and we can take out the tissue. This is regularly practiced for any suspicious ovarian mass, be it in menopausal or other variants. So this is how then we fold it, and this is loaded through the vagina. This is another case. Look at the video, ultrasonography. There was some suspicious growth, fine suspicious growth was there. And we went for, there was also some collection of the hemorrhagic collection. That was the cut section. But in this case, we only went for the TLH and BSO. And this came out of the serous papillary tumor of variety, micropapillary variety. And some of these cases really, it comes malignant afterwards. They really backstab you because the obvious picture is that there was malignancy was there, and we have not done the full-scale surgery, and patient may claim that why you have not gone for the full-scale surgery. So that there we must be very much aware of the fact. And some of the cases which if you do are the obsession. The laparoscopy is no, in a solid mass, retroperitoneal mass. Of course, Dr. Pandit has shown how the mass has to be taken out. But some of the masses which are suspicious should not be done. Vascular mass with low resistance. This was the case with a perimenopausal lady whose CA125 was 47. MRI was suggestive for the broad ligament myoma, and we went for it, and it come out to be an invasive mode. The message is that in a menopausal lady, that is case of myoma, unless and until it is excluded and everything. So the possibility of the malignancy should be there in the mind. for a menopausal lady, particularly with the diagnosis of the myoma. This was another case with solid component of the left side ovary. This was solid ovarian mass, multiple times surgery earlier for the chocolate cyst, and now it has come, and there was obvious malignancy was there. So in this case, our counseling is that if possible, we will proceed for the surgery. And patient was stable, and we proceeded for the surgery laparotomy, and we took out everything with peritonectomy, with full scale of the surgery, and because we are equipped with oncological setup, so we have no problem. We counsel the patient accordingly. First, we go for the D-lab, diagnostic lab, and then accordingly decide. So this was the thing, and the biopsy, everything it was noted in the biopsy report. It came out to be the mucinous adenocarcinoma of the ovary, possibly metastatic from the colorectal. So another case, huge ovarian mass with multiple thick septa, they are there. And this was mucinous cyst, definitely. But the only thing is that there was mucinous, there was thick septa, there, vascular septa, there. And in this case, if I go for the laparoscopy, this is absolutely an obsession with such big mass. So there, the laparoscopy is a no, and there we should go for the open surgery. Here again, small ovarian masses, but with a lot of ascites. Here, our plan is to go for the diagnostic laparoscopy and to assess the digits. The PCA scoring has to be done. And in this case, we took out the biopsy and we subject the patient for the chemotherapy. And after 3 cycles of the chemotherapy, we went for the full-scale surgery. So this was another case of a menopausal lady who had also earlier surgery for some reason. And this was the case with bilateral ovarian masses. And of course, CT scan is done for all cases to assess the disease extent, disease invasion, and of course, the C125 level was 229. In this case, our plan was to assess the disease and to find out that what can be done. So there was certainly ascites was there, and there was florid malignancy was there everywhere. And we took out the biopsy from this case, and then we sent the biopsy. The biopsy came out to be the immature teratoma and tumor, but decided that we should go for the primary surgery for this case. And we again built up the patient. After 10 days, we operated the patient. So laparoscopy proceeding for such cases is an obsession because it needs a full-scale surgery, satisfying the full malignancy criteria, the peritonectomy and everything has to be done. These are small ovarian masses, but with huge ascites. Here, the scope of laparoscopy is only to go if the peritoneal cytology fails or the FNSC fails. Then your job is to go and take out the tissue for the biopsy and to assess the disease status. That will help afterwards. This was again a menopausal lady with small ovarian cyst left side. We went for, but we suspected that this might not be a malignancy. This was a case of tuberculosis. So we took out the biopsy, and biopsy was come out to be the tuberculosis. ATT was given, and after 6 months, we operated the case. So this is another opportunity, PIPAC, the pressurized intraperitoneal aerosol chemotherapy, which can be given for an advanced malignancy. So friends, experience is nothing but accumulation of our mistakes, and we can learn from each and every case. Learning from own experience is brilliant, but learning from others' experience is genius. So nothing is a waste of time if you set the experience wisely. And thank you all for listening this. What I want to ventilate to all of the youngsters is that every ovarian malignancy should be analyzed properly. Proper planning has to be done, and proper procedure as per the guideline has to be there. So this is what I want to ventilate. Thank you everyone for watching me, and thank you organizer for the opportunity. Thank you all.
Thank you, Dr. Manoranjan, for a nice talk. And you have excellent collection of the ovarian different masses. And you have well said, ovarian mass, in spite of all investigation, there might be a chances of malignancies there. So whenever you deal with any ovarian mass, always deal in back. And if there is a bigger mass, always do debulking in bag, and there should not be a spillage. Then and then you can prevent the further morbidity to particular patient. Thank you so much, Dr. Manoranjan.
Thank you. And thank you, Dr. Bhaskar, once again, and all the best for the your venture. Thank you all.
So now I would like to invite our next speaker, Dr. Sandesh Kade, for his talk on robotic surgery in management of anterior compartment in gynecological surgery. So Dr. Sandesh Kade is Director of Advanced Gynec Institute at Burjil Medical City, Abu Dhabi. And he has credit of so many awards and everything. And he is one of the best friend, young buddy. So stage is yours, Dr. Sandesh.
Hello friends, today we are going to speak on a very important and a pertinent topic, that is the pelvic nerves. The topic is very confusing and very volatile. Now the pelvic nerves or the nerves are very sacred, and they are the powerhouse of our body, and that is the reason they are very remotely located, so that they are away from human interference. This reminds me of our Indian gods and goddesses temples, which are also very remotely located and are very sacred to us. Why I say this topic is confusing is because we have to understand certain neurological facts, and we will try to understand what exactly is the nervous system. It is made up of two parts: the central nervous system and the peripheral nervous system. Now central nervous system is made up of the brain and the spinal cord, whereas the peripheral nervous system is made up of somatic and autonomic system. The somatic goes to the skeletal muscle, the voluntary, while autonomic goes to the internal organs, which are not under our control, they are involuntary. So the voluntary would be divided into sensory and motor, whereas the autonomic system is divided into sympathetic and parasympathetic. The sympathetic system works involuntarily in the state of fight and flight, whereas the parasympathetic activity happens in rest phase, that is rest and digest. There are cervical vertebrae, thoracic vertebrae, lumbar vertebrae, sacral vertebrae and coccyx. Now in the thoracic part of vertebrae, you have a dorsal horn and a ventral horn. So in the vertebrae in the thoracic and the sacral part, in the midline there is one nucleus which is very special in thoracolumbar areas, not sacral, thoracolumbar area, and this gives special nerves which are called as sympathetic nerves. So the fibers arising in thoracolumbar part are sympathetic fibers, whereas the fibers arising from the cervical and sacral part are parasympathetic. We have to understand the autonomic nervous system that controls the pelvis. So we have to discuss where does sympathetic come from and where does the parasympathetic come from. So if you consider this as the bifurcation of aorta, you will understand that from the thoracolumbar, the nerves which come will fuse in front of this bifurcation. This is the superior hypogastric plexus. This is sympathetic plexus. From here you have two fibers, one which goes on the right and another on the left side. This is called as the right hypogastric nerve and the left hypogastric nerve. This again is sympathetic. Here you have the organs, the bladder, the uterus, cervix and vagina, and the rectum. And this is the uterosacral ligament. So we have to understand that lateral to this hypogastric, the uterosacral ligament, you have the superior hypogastric nerve which comes here, and below this level L4 L5 you have sacrum. From sacrum there will be S1, S2, S3, S4. These nerves will be arising and they will form the sciatic nerve joining the lumbosacral trunk. These in turn give the other nerves which are called as the pelvic splanchnic nerves. These are parasympathetic. So lateral to the uterosacral you have a complex which is called as inferior hypogastric plexus, which is joining of the sympathetic nerve and the pelvic splanchnic, which are parasympathetic. And from here onwards the nerves which go to the bladder, to the uterus and cervix and vagina and to the rectum are mixed nerves which will carry both the sympathetic as well as the parasympathetic commands. So this explains the autonomic nervous system of the pelvis. We have to be very careful at the uterosacral ureteric dissection so as not to injure these nerves. These nerves have specific functions of contraction. The parasympathetic have the function of contraction of these organs, whereas the sympathetic will control the sphincters of these organs, and there is a very good interplay between these two systems which help these organs to function well. If you cut these parasympathetic fibers, there will be no contraction of the bladder, no contraction of the uterus cervix, or there will be dysfunction of the vagina and of the rectum. So if the rectum does not contract, it will have chronic constipation. Bladder does not contract, the patient might need self catheterization, and if there is dysfunction of the vagina, there is loss of lubrication and there is dryness of vagina. So these are the problems that can arise if you damage or injure these nerves. Now let us see the clinical application of this knowledge of lumbosacral trunk in genitofemoral nerve, which supplies the mons pubis and the inguinal ligament area. Then another nerve is the obturator, which has root value L2 to L4, which supplies the inner and the medial aspects of the thigh. And the third nerve is the lumbosacral trunk L4 L5. So this we'll see in one case. She is a case of right leg pain, and she had involvement of the lumbosacral trunk. So in this case we will see all these three nerves which are seen dissected. So here we are on the right side of the pelvis. Psoas muscle is seen. We are dissecting lateral to the external iliac. We are preserving the genitofemoral nerve, which has two branches, the genital branch of the genitofemoral and the femoral branch of the genitofemoral. So we are cutting on the medial aspect of the psoas major muscle, and we are very careful when we come to the external iliac vein. Once this dissection is done, then we go lower down, and here you will find a fat pad, and it should remain like a curtain from the external iliac artery and vein. And within this fat pad you will find a nerve which is the obturator nerve, the root value L234. So this nerve runs anteriorly and enters into the obturator canal. This is the anterior compartment where you will see the obturator internus muscle. So in our regular cases, we should not expose the nerves unless you want to just identify it. So just that fat curtain, we know where the nerve lies. So this is the the obturator nerve. And if you go lower down to the obturator nerve, you will find the lumbosacral trunk. Here I am seeing very large dilated tortuous vessel, the superior gluteal vein that is running over the lumbosacral trunk. Ideally, it should run below the lumbosacral trunk and between the piriformis muscle. In this case, the vein is seen running over, but the patient had pelvic varicosities, and that is the reason this was compressing the lumbosacral trunk, and hence these cases are called as neurovascular conflict. Mere presence of these veins does not warrant removal of or cutting of those veins. If the patient has varicosity, thickening of the vessels, the diameter is increased, it is compressing, and there is pain, only in those cases we tackle this neurovascular conflict cases. So here you can appreciate very large lumbosacral veins, I mean the lumbosacral getting compressed against the bone, that is the ala of the sacrum. And here we are coagulating the larger ones and we are cutting. This lumbosacral trunk will be joined by the sacral roots, and those sacral roots S1, 2, 3 and the lumbosacral L4, 5 will form the sciatic nerve. The sciatic nerve in turn on its way down will give the inferior hypogastric nerve, the superior hypogastric nerve, the superior gluteal and the inferior gluteal nerves, which will go outside. The sciatic nerve will later exit the greater sciatic notch below the piriformis muscle, and there will be only superior gluteal and the superior gluteal vessels which will go above. So you have many structures going below the piriformis muscle, while you have only two structures going above, and then the S12 will be later joined by the S234, and that would be the pudendal nerve, which will enter below the sciatic. So this is the pudendal nerve. This nerve exits the pelvis and re-enters. It has three nerves at the terminal end. One at the innermost, that is deep perineal pouch, which supplies the clitoris and the urethra. Second is in the superficial part. Next is the superficial perineal pouch, which supplies the labia majora area, and third is the inferior rectal nerve, which supplies the lowermost part of the perineum. Now we will see on a cadaver how the nerves are formed. So here you can appreciate the, that is the lumbosacral trunk. This is the S1 root, which is very thick and joins the lumbosacral, and this is S2 root, and then in the lower part you can see how thick is the sciatic nerve, and this S2, S3, S4 will join and they would form the pudendal nerve. So this is on the lateral wall. You appreciate the sacral roots coming out and joining and forming very thick large sciatic nerve, the pudendal nerve, and they are exiting out of the pelvis through the greater sciatic foramen, and so they go out into the thigh. So now let us see hypogastric nerve in a real case and how we preserve and conserve it. This is a case of precedentia, and at the sacral promontory we have incised lateral to the rectum, and here you can see we are just cut the superficial peritoneum, and here we will identify the right hypogastric nerve. The nerve would appear like a pink structure with its own blood supply carried along with it. So here you will see this is the right hypogastric nerve. So we will always operate superficial to this nerve. We are in the mesorectal fascia. So this is truly nerve preserving surgery. And here you will see then we go down towards the uterosacral ligament, remaining medial to the right hypogastric nerve, and our mesh would lie in this plane within the fascia so that it does not invade into the rectum or onto the nerve or into the presacral. Here I have just dissected the presacral area, which we will identify and preserve the hypogastric fascia. And this fascia, if you trace it upwards, it would come to the sacral promontory. And like we were doing in our earlier days, cutting at the sacral promontory, sometimes the right hypogastric nerve was getting cut. To expose the right sacral promontory, you don't need to cut at this plane. And here we have jumped over and preserved the right hypogastric nerve and gone down into the pelvis. So appreciate the right hypogastric nerve. This is the superficial hypogastric plexus, and just by lifting the superficial hypogastric plexus, the sacral promontory gets exposed. So it is not to be cut but just identified and lifted up. So just lifting the superficial superior hypogastric plexus and the right hypogastric nerve, the sacral promontory is exposed for us to fix the mesh, and the level of dissection ends when you see the middle rectal vessel. So this is for the pelvic floor repairs, where we preserve the superior hypogastric plexus and the right hypogastric nerve, that is the sympathetic supply of the pelvis. We need not expose and pull on the nerves to show and preserve them. I will show you one more case where we do not actually expose but yet preserve, because it is known that if you pull on the nerve, mere pressure of 40 grams is enough to cause neuropraxia. So in this case, preserve the fat around the nerve, very important, and understand that the nerves always travel through fat pad and preserve themselves. So we should preserve the fat area, and that would save the nerves. Here I am just demonstrating the relation of the right ureter and the relation of the right hypogastric nerve. So this is the right ureter and the level of the hypogastric nerve. This is another case of bowel resection, where we have preserved the hypogastric nerve but not exposed them. I will just show you by mere stretching. The superior hypogastric plexus is stretched, and that would delineate the left hypogastric nerve, so you don't have to expose. That's what I want to highlight. So this is left hypogastric nerve preserved, and then when I pull on the superior hypogastric plexus on the right side, I would see the right hypogastric nerve. So now when you come to applying the staplers, you can just pull on the rectum and be careful and mindful of the nerves, and then the stapler is turned, and then you apply it to the rectum to fire it. So in this case, you are actually conserving, observing, and being careful of these nerves and preserving these nerves, so as well as the functions of these rectum. So this nowadays, the understanding of the knowledge of nerves has improved our surgical outcome and functionality of the patients. So thank you very much for this wonderful opportunity, and do follow us on YouTube, because we will be coming up with more videos on neuropelviology. So thank you very much.
Thank you, Dr. Sandesh. As usual, your nice and excellent presentation. And you have rightly said, understanding the knowledge of nerve is most important, because nowadays we have more and more endometriosis advanced cases. In that, we have to understand the anatomy course of the nerve, and nerve preserving surgery is really helpful to the patient. It's an excellent talk. So
Hi, Dr.
Yeah, I would
Sandesh,
like to
could I
take
ask
this
one question?
opportunity to thank Bhaskar and wish him all the best. Yeah, sorry, what was your question?
Yeah, Dr. Sandesh, I'm sorry to interrupt you. I'm Dr. Usha M. Kumar here from
Yeah.
Delhi. So I know this endometriosis, many times we dissect the pararectal space, and in sacrocolpopexy also, there is very high possibility of injuring to the hypogastric nerve, and patient, they do come back with the bowel problems. So what are your views on pactopexy? Because we are not interfering with these nerves when we do apical fixation for the prolapse.
But even in pectopexy, we have seen patients. I have myself removed the mesh in majority of the cases. When you use excess mesh, it is not only cutting the mesh, but even if you suture it, or like you have patients, surgery patients who do hernia repair, and they come with acute pain the very next day when they have nerve entrapments because of suturing. So the pectopexy mesh also should be fixed only to the bone, and it should not extend over the psoas muscle where you have the genitofemoral nerve. So we have everywhere in the pelvis you will have some nerves are there. So we have to be careful at each and every situation, and we cannot change our procedure. It will depend, the prolapse surgery will depend upon what compartment defect is there. Suppose the patient has anterior compartment defect and I perform a sacropexy or sacrohistropexy, because I know sacropexy, I will increase her complaints, because I will open the anterior compartment more, and her cystocele will become more evident and more symptomatic, and she will have more leak. So if I have an anterior compartment prolapse, then I will prefer a pectopexy. But not when the patient needs I will not go because I know only one procedure. We have to act according to the pathology of the patient.
Yeah, right, absolutely right. But now I have modified my pectopexy also, like not to interfere with obturator nerve, not to interfere with the genitofemoral nerve. What I do, I'm using AbsorbTech on the vaginal wall, and I'm using capsule on the pectineal ligament. So just I'm using the minimum mesh required. It's not, if you feel this is excess mesh we are using, we can cut it off. So I'm just using 2 centimeter of the mesh, and then with the T-shaped form, and just fix it up with the AbsorbTech on the anterior vaginal wall and the capsule on pectineal ligament. So really, I think it's a completely ruled out to interfere in any of the nerves in the anterior compartment. As you said rightly, we can use it only for the apical prolapse, for the anterior compartment prolapse. And depending on the patient situation, we have to go.
Correct, correct.
So we have one question. That is what the question is by Dr. Japlin Kaur. What are the indigenous alternatives to endobag, which are cost effective and efficacious?
I'm not aware of any. I'm sure there would be. I'm not aware of an endobag. When you are not worried about microspillage, then you can use any other bag. But if you are worried about microspillage, you have to use the Morse bag. And as I said, that for fibroids, the alternative is to take it out to the pouch of Douglas.
Thank you, sir. There was another question for Dr. Manoranjan Mahapatra regarding the advantage of lab biopsy over USG-guided biopsy, which sir has answered. And another question was for Dr. Abhishek Chandravarkar, but I think sir has left. If anyone would like to take it. Is there any experience of uterine artery ligation in secondary hemorrhage from vault after hysterectomy and in secondary PPH in post-CS case? And if so, which approach? This is a question by Dr. Shamali Banerjee. If anybody would like to take it. I think sir has left. So we have no further questions. Thank you so much to Dr.
No,
Mehul.
for this case, lateral approach is the post-hysterectomy and the post-CS. The lateral approach is the best approach in this case. And uterine artery ligation sometimes may not be helpful. In that case, internal iliac ligation will be helpful, because the vaginal artery, if there is bleeders are there, the uterine artery ligation may not be helpful. So in that case, there is a situation in which we can go for the internal iliac ligation.
I just have one more question for Dr. Paul. So how do you decide, do you go for endobag collection for all myomectomies cases, or do you go selectively for some patients?
You didn't get the question. How do you decide?
So do you use endobag for all myomectomy patients or the selective patients?
No. Well, I personally see this is a very, very contentious issue, in the sense I have this debate of many of my younger colleagues who say that most patients will become a problem because the endobag adds to the cost. If I have to morcellate, I always morcellate in a bag. I never do a naked morcellation. And otherwise, I would take it out through the pouch of Douglas. And there are instances I have seen people to save costs, they're making a small incision and taking it out. So these are your three options, but I wouldn't advise morcellation without a bag, not so much for leiomyosarcoma, but more so because of the diffuse leiomyomatosis, which see much more commonly.
Yeah. Right. Thanks for the answer.
There are no further questions in the chat box. So I would like to thank our chairpersons, Dr. Mehul Sukhadia sir, Dr. Suman Puri madam, and our four speakers, Dr. Bhaskar Pal sir, Dr. Abhishek Chandravarkar sir, Dr. Manoranjan Mahapatra sir, and Dr. Sandesh Kade sir. We would like to move on to our third session, which is an interesting panel. And to take over, I would like to hand over the proceedings to my co-MOC, Dr. Prerna Keshan.
Thank you, Poshali, and wishing you all a very good evening. And indeed, we have been on a roller coaster ride for the last 2 hours with academic inputs on various aspects, ranging from basic anatomy to advanced laparoscopic procedures, with a galaxy of stalwarts from across the country. With our very best wishes for the brainwave behind the entire show today, Dr. Bhaskar Pal sir, for his ongoing Foxy presidential elections, we move on to the last session of this mega episode 8 of Endovision Web Meet. With this, we invite our moderators for the panel. Panel discussion will be on myomectomy and minimal invasive surgery, the do's and don'ts associated with it. And our first moderator is Dr. Kalyan Barmade sir. Dr. Kalyan Barmade sir is the Secretary IAG 2023-24 and the Chairperson Infertility Committee.
Prerna, he is currently the Vice President of IAG. He was the Secretary of IAG in 23-24, and for 24-25 he is the Vice President. You can also call him the President-elect of IAG.
Thank you, Dr. Prerna, for a nice introduction.
Sir has been the Chairperson of Public Awareness Committee of Foxy. Thank you, sir, for being with us. We are really, really honored to have you amongst us. Our next moderator is Dr. Balaji Pandit Rao Nalwad. Sir is the HOD of OBGYN Department, Manipal Hospital, Baner, Pune, and he has various affiliations to his credit and has almost 5 international journals in index journals, and has been the organizing secretary of UIA IAG Endoscopic Conference in 2015. We are honored to have you.
Not many people on the national stage know him. He was a brilliant and gifted endoscopic surgeon based at the present moment in Pune, although originally he is from Latur. And he has also done his post-graduation from the my alma mater of post-graduation, that is Lokmanya Tilak Municipal Medical College. And welcome, Balaji.
Thank you, sir. Thank you for the kind words.
Welcome, sir. Dr. Kalyan, sir, would you like to introduce your panel?
You introduce everybody and then we'll start the panel.
Okay. First panelist, Dr. Subhagya Kumar Jena. He is a professor and OBGYN from AIIMS Bhubaneswar. Welcome you, sir, for this esteemed panel. Next panelist is Dr. Shashank Shekhar, sir. He is the IOGS Gynae Onco Fellow, UCH London, and is a professor and unit head of OBGYN Adjunct Faculty School at Public Health, course coordinator, fellowship in Lab Gynae, AIIMS Jodhpur. We welcome you, sir, for your esteemed presence. Our third panelist is Dr. Shrikant Odi, sir. He is from the European Academy of Gynecological Surgery, Belgium. He has done his minimal invasive surgical certificate course and is a course trainer at Foxy Approved New Life Advanced Laparoscopy Center, Varanasi. Welcome, sir, for your esteemed presence. Our next panelist is Dr. Sriram Iyer, sir. He is currently working at Sri Balaji Hospital, Mirar, Maharashtra, and had served as associate professor 2 years in OBGYN at the Amrita Institute of Medical Sciences, Kochi, has various awards and affiliations to his credit, and he has laparoscopy trained and got short-term experience at various national dedicated teachers and faculties, naming a few of the stalwarts across the country. Our next panelist is Dr. Sonu Singh. Dr. Sonu Singh has a present position as Senior Consultant Laparoscopic Surgeon at the Vivekananda Polyclinic and Institute of Medical Sciences, Lucknow. We welcome you, ma'am. Ma'am is a member of various organizations and has various affiliations to her credit, and has an area of interest is basically endometriosis accident surgeries. Welcome you, ma'am, to this esteemed.
Sonu might not be able to join.
Our next panelist is Dr. Usha M. Kumar. who is at the Max Super Specialty Hospital, Saket, New Delhi, and has, to her credit, is almost more than 10,000 endoscopic surgeries. Hats off to you, ma'am, for your credibilities, and we welcome you, ma'am, for your esteemed presence. Our next panelist is Dr. Varsha Patil, ma'am. She is a chairperson of AAGL Ahmedabad and speaker at the Horizon Trisur 2019 and many other national international conferences. Welcome you, ma'am, for your
Young
esteemed
endoscopic
presence.
surgeon from Solapur.
Sir. Request Dr. Kalyan, sir, to kindly take over the panel.
Yes, ma'am. I welcome everybody. I think except Dr. Sonu, we have everybody joining together today.
Yes, sir.
There is some technical issue. Just wait for 1 minute. I'm audible, Dr. Balaji?
Yes, sir.
Yes. So we are going to talk on myomectomy in MIS, do's and don'ts. I welcome Dr. Balaji Narwar and all other panelists. So fibroids, we are going to talk on current evidence for management of infertility, laparoscopic myomectomy and hysteroscopic myomectomy. As everybody knows, uterine fibroids occur in up to 30% of the women of reproductive age group. Fibroids may cause infertility by obstructing the tube and impairing the gamete transport. Critical factors are distortion of the endometrial cavity and abnormal endometrial receptivity and hormonal milieu. Professor Kurt Sem reported first lap hysterectomy, myomectomy in 1979, followed by lilometla. Fibroids are commonly seen in infertile patients. So everybody knows the FIGO classification of leiomyoma. That is submucosal. 0 is pedunculated. 1 is more than 50% submucous. 2 is less than 50% submucosal. And followed by 3 as 100% intramural. 4 as 100% intramural, no endometrial or subserosal contact. So how do fibroids cause infertility? So over to Dr. Shashank. You have to unmute Dr. Shashank.
Well, fibroids, in a workup of infertility, if just mere presence of fibroid should not, lead to the assumption that this is the reason for infertility. What I practice is and what I preach is, when you're investigating a case of infertility, when you have no other reason to believe that that's the cause of infertility, then probably, because the association between fibroid and infertility is a very sticky one. And how does it cause? It may interfere with the implantation if it is submucous one, particularly the posterior wall where usually the implantation occur. Theoretically, if there are two fibroids near the cornua, the uterine cornua, it may obstruct the fallopian tube, its entry into the uterine cornua. And there is possibly it might interfere with the uterine milieu, thus again compromising the implantation. Again, the caveat is that when you're investigating infertility, just presence of a fibroid should not lead to the assumption that this is the reason. When you have ruled out everything else, you have a submucous fibroid, posterior wall, probably it might be the reason.
Very rightly said. Dr. Usha Kumar, you want to add something?
Yeah, I do agree with Dr. Shashank completely. So whenever I think you have investigated completely the couple and then you don't find any other reason for infertility and you see the fibroids, even if it is single fibroid and she has got a small fibroid, 2 to 3 centimeter, this can lead to infertility, can also lead to subfertility. But sometimes there is implantation failure, sometimes there is a recurrent pregnancy loss. So, in my opinion, we should go and treat such patients. And for infertility patient, what I have decided that see and treat approach. So, even if something is not evident on ultrasound, I go ahead to do diagnostic laparoscopy and diagnostic hysteroscopy, see and treat. So, if there is any coincidental finding at the time of doing surgery, if I consented before doing the surgeries, then you can always remove the fibroid in the same sitting.
Okay, rightly said. So, Dr. Shrikant Ohri, what are the indications of preconceptional myomectomy in your clinical practice?
So, if the patient preconceptional myomectomy, if the patient has pressure symptoms, the bowel discomfort or any bladder dysfunction, and there is exactly that pressure and it causes pain, then you have to do the myomectomy before conception. And if the size of the fibroid is more than 4 centimeter, again, and there are multiple fibroids, you have to go for myomectomy before advising the patient for conceiving.
Right, Dr. Varsha, you want to add some other indications for myomectomy? You have to unmute Dr. Varsha.
Yes, sir. Good evening, sir.
Good evening.
Sir, it is said that fibroids produce some hormones which are hindering the fertility. So we have to take them out whenever we encounter a patient of infertility with fibroids. Probably prolactin is the hormone. I think I'm not sure about it, but some
No,
hormone. It's like. So we have to remove fibroid anyways. I mean, whenever we encounter with fibroids, and if they are at the junctional zone of the uterus, then they hamper the motility. So we have to take them out hysteroscopically. So yes, sir. Whenever we encounter with
yes. Dr. Saubhagya, you want to add something about the indications? Yes, Dr. Jana.
Good evening, everyone. Let me first thank Dr. Bhaskar and his team for giving. I hope I am audible.
Yes.
For this opportunity, and I believe coming to the question, I think almost all parts has been covered. Starting from location of the fibroid, size of the fibroid, then what are the symptoms they produce, and coming to that answer by Dr. Shashank, whether other causes of fertility has been excluded or not. So, and cervical fibroid, huge fibroid, cervicous fibroid, these are the indications for going for myomectomy.
Right.
Nothing extra to add.
Those fibroids causing effect on the urinary system, as rightly said by Dr. Shrikant, hydronephrosis, those where there is a rapid rise of size in the fibroids, like sarcomatous changes, may be there in some patients. So you go for a myomectomy. So what are the cases where you are not going to do a myomectomy? Dr. Varsha.
So basically, if the patient is not willing, then we cannot go ahead with myomectomy. And when the size of the fibroid is much small, like 1 centimeter or 2 centimeter, when we are going to cause the damage to the uterus, like it is intramural, or we have to cause so much myometrial damage, then we have to wait and watch if we can.
So the smaller subcellular fibroids, pedunculated fibroids, fibroids less than 2 centimeter, and asymptomatic fibroid doesn't require any of the indications of myomectomy. So Dr. Shashank, whenever you have a solid reason of doing a myomectomy, what are the pre-operative counseling you are going to do with the patient? Dr. Shashank Shekhar, you have to unmute, please.
Yeah, thank you so much. So preoperative counseling regarding lap myomectomy, I guess you're saying.
Right, sir.
the patient needs to be counseled about the procedure and the risk inherent in the procedure. The patient needs to be told about the blood loss, need for blood, need for conversion, need for hysterectomy, and tissue retrieval. Patient needs to be told there is, although that's a very, it's a rare chance, US FDA says 1 in 500, but in reality, the chances of finding a malignancy is rarer than that, but that is still a possibility. And the tissue retrieval should be discussed with the patient. We have had a lot of discussion, I think, in the previous sessions regarding how to retrieve the myoma. So and the recommended methods is either you do in-bag morcellation, or you do a power morcellation, or you put it in some kind of an endo bag, give a suprapubic incision, put a Valexis wound retractor, and then do a manual morcellation. So tissue retrieval, possibility of malignancy, and then chances of recurrence. The recurrence rate about 20-25%. So that will be not just the recurrence, but need for reoperation. Some studies quote somewhere around 20%. Need for reoperation. Every recurrence does not need a reoperation, but the reoperation rate is around 20%. And this is more so in younger patients. See, if somebody is in late 40s, for some cultural reason or personal reason, somebody is not willing to, get hysterectomy done and wants to have a myomectomy after 40s, then chances of recurrence is less compared to if somebody is younger in age.
Okay, you talk about the chances of hysterectomy. What are the cases you are going to counsel her about a chance of hysterectomy? What are the cases you have encountered in your practice?
Multiple fibroids, large fibroids, uterine size more than reaching above the umbilicus, location, ligamentous fibroids, cervical fibroids.
Difficult fibroids and multiple fibroids, rightly said. Dr. Shriram, what is your view about the hysteroscopic myomectomy, and what are the size you are comfortable for doing a hysteroscopic myomectomy? Dr. Shriram Iyer? Yes, Dr. Shriram, welcome. Dr. Shriram, I think you are not audible. Yes, please, now. I think you need to be... You are not audible, Dr. Shriram.
Okay, let's pass the question to other panelists.
I think Dr. Usha Kumar ma'am will be...
Yeah. So the thing is, hysteroscopic myomectomy, which I'm comfortable of doing, is FIGO 0 and 2, 1. So up to 2 to 3 centimeter of the fibroids, one can remove comfortably hysteroscopically. And I have used this mechanical morcellator. So it's touch and just to touch it and cut and suck in one go. So that instrument is very good to remove such fibroids, and bleeding is also quite less with such this equipment. And the tissue retrieval is really not the problem, because you need to just touch the equipment to the top of the most prominent part of the fibroid and start the surgery, and then it really cuts into nice pieces, small pieces, and take it out in one go. So that is one way. But if it is more than 3 centimeter, then sometimes it's difficult to retrieve the whole tissue hysteroscopically, and if it is associated with other intramural fibroids, subserous fibroids as well, then I take a laparoscopic approach. And I do remove all these fibroids laparoscopically. Sometimes there is a fibroid which is FIGO 2 or FIGO 3. Then it's better to go ahead with the laparoscopic resection. And even if you open up the cavity, then also not the problem, because earlier days people used to suture the cavity with the 3-0 Vicryl and all. But nowadays, I think it's no more indication to suture the endometrial cavity. But you can very well retrieve, like in some patients, there are multiple submucosal fibroids. So I always prefer laparoscopic approach, open the cavity, and then take out all fibroids.
So Lasmer classification is useful for you, ma'am, while you are going to decide whether it's going to be a lap
Yeah.
approach or histo approach?
Yeah,
What is
definitely.
LASMER? Are you using it? Step W classification?
Yeah, I'm not using much this Lasmer classification, but I do go for FIGO classification. So depending on I mean, I'm not that very too much into hysteroscopy, but I always prefer laparoscopy where it's required. But whenever it's you see it's only some mucosal fibroid and it's 0, 1, or then I go ahead with the hysteroscopically. But if it is more than 3 centimeter, more than 50% of the part is intramural, I always go for the laparoscopy.
Okay, Dr. Usha ma'am, we are using this LASMER classification where you're going to take into consideration giving points of 0, 1, 2, penetration less than 50%, size, base and lower third or middle upper third. And depending on the scoring system, if it is 0 to 4, non-complex, 100% hysteroscopy. 5 to 7 is a complex where you need to take a consent that you might require a 2-stage surgery. And group 3, 7 to 9 score is always a laparoscopic myomectomy. So this is an influence. As everybody knows, submucous fibroid and infertility go hand in hand, and hysteroscopy can only diagnose these pathologies. Also, in the same setting, we can remove these pathologies. So, what are the tips and tricks while doing a hysteroscopic myomectomy? Doctor, anybody can take this.
So
Doctor,
for hysteroscopic
yeah,
myomectomy,
yeah, Dr. Sri.
so once we enter the uterine cavity, first we have to look for the anatomy of the uterine cavity. First, we have to see both the osteas and then locate the fibroid. So once the fibroid is located, we decide to use the resectoscope or the scissor can be used. So if we are using the resectoscope, we generally use it nowadays. We generally use it under normal saline with the bipolar current because of the reduced risk. But again, there is a risk with this normal saline also. So with resectoscope, we always have to put the blade of the resectoscope beyond the fibroid and then pull it towards ourselves. We never try to push it towards the fundus because it can lead to damage of the fundus, and again, bowel damage can occur with this current. So we always try to pull it towards ourselves. And with resectoscope, there will be debris formation with the fibroid tissue. So we can remove the we can remove the uterus resectoscope in between, and all the debris will come out. And again, we can reintroduce and then restart the procedure. And so we can also stop the procedure for a minute after doing the myomectomy, after doing this myomectomy. And once we start the procedure, we see the fibroid coming out into the cavity from the myometrium. So again, like this, we can remove the residual fibroid tissue also. So this is how we do the resectoscopic myomectomy.
So whenever you are going to reintroduce it, are you going to give some injection like oxytocin or something, or you just wait for the?
So we don't give any injection. We introduce it and we do it.
How you are going to? What are your tips you are going to give to prevent hemorrhage during TCRM? Any drugs you use prior?
Yeah,
we can use.
Yeah, Dr. Varsha, you can add.
So we can use vasopressin. We can inject it paracervically at 3 o'clock and 9 o'clock position. That also can reduce the hemorrhage during the myomectomy. And if it is pedunculated, we can go ahead with scissors also. And if it is a sessile one, then we should think about when we have to go with the using energy source. If it is pedunculated, we can go ahead with using scissors also.
Okay, anybody has any experience of using GnRH to decrease the size as well as hemorrhage?
Dr. Kalyan, I have been using 20 units of syntocinon at the time of surgery. So even for the hysteroscopic myomectomy, laparoscopic myomectomy, if you just put it in 500 ml of the saline and run it at the rate of 40 milli international unit per minute, and it really helps to reduce the bleeding miraculously. And it's very useful in the patient where the vasopressin is contraindicated. And we all know there are so many side effects of vasopressin. So nowadays, I'm preferring to start that syntocinon drip rather than using vasopressin. And it's really working beautifully. Most of the person.
That's great. Dr. Sobhagya, you wanted to add something.
Nowadays, my surgery are quite good.
GnRH, yes, definitely we can use prior to surgery when preoperative planning. there are controversies, there are advantages and disadvantages. But if it is highly vascular and size is appropriate, I do prefer preoperatively using it. Second point I want to highlight that the intraoperative PPs try to remain in between the capsule, give a cut because the blood supply, because our main idea is the operative feed should be clear and blood loss should be less. So if you will get the chips and remain from above to downwards and remain in between the capsule and as possible to a myometrum, we are not going to the myometrum. I think we can prevent the bleeding.
Okay, rightly said. Dr. Usha ma'am, you are using these hysteroscopic morcellators. So we have a
Yeah.
dual approach for this. A part of the fibroid can be removed with the hysteroscopic morcellator, and the remaining part, if it is going to be difficult, then it can be used. A resectoscope can be used. This is called dual
It's a
approach.
very good idea.
Rightly said. Anybody wants to add about hysteroscopic? Dr. Shashank, you want to add some points before winding up the hysteroscopic myomectomy?
Oh, thanks, Dr. Kalyan.
Okay. So to summarize, you have to be in the capsule. You have to use GnRH agonist first. If you are thinking that your fibroid is more than 1 centimeter of the thing you are doing, like if you are doing for a 2 centimeter routinely and the fibroid is 3 centimeter, then 1 month back, 1 month prior, you can give GnRH so that the size will become 2 to 2.5 centimeter. Vasopressin is going to be helpful. As far as possible, don't come out of the cavity whenever you are doing a resectoscopy, because there are reported cases of air embolism if that air remains inside. So as far as possible, or then you have to use vasopressin. There is another advantage of vasopressin is it decreases bleeding as well as it decreases the absorption of the fluid. And we have to be very careful that one person should be in the OT monitoring the fluid deficit, which is happening. And if you are judicious enough, then you can finish off this surgery within 20 minutes. Then it's good time to finish before the deficit is more. So now coming to the...
Wait something.
Yes, please.
In relation to vasopressin, all of us know that we are routinely using and we are using also. But I feel everybody should understand that this is a off-label use.
Oh.
So that should be kept in mind actually. If any problem occurs, we are vigilant, we are informing the anesthetist, we are using it day and night, but it is a off-label use.
No, even we have a SCOG recommendation where now it's on-label use. I can, Dr. Saubhagya, I can give you the references at the end of PPT. I can share you with the... But it's recommended to prevent the fluid deficit. Yeah, Dr. Shriram, I think you are audible now. Now, still you are not audible, Dr. Shriram. You need to zoom out first and then come back again to join the Zoom meeting. We are not able to, or we can only able to see you, can't hear you. So now coming to the FIGO L3 classification, or to Dr. Balaji Nalwar.
Thank you, sir. So can anyone highlight about the mapping of the fibroids before starting with the surgery? Any of the panelists can. Dr. Saubhagya, sir, please.
Mapping means what we want to do is the location and size of the fibroid actually. Doing by imaging techniques. The commonly used imaging techniques, usually routinely we are using is ultrasound. But if you have difficult cases associated with some other pathology or something, even if it is not possible to clearly find out the location and size, numbers and all these things, then we can take up the help of MRI. But routinely, I prefer what is to do an ultrasound, preferably if size is less than 12 weeks, usually transvaginal ultrasound, and if it is more than 12 weeks, combined transvaginal and transabdominal ultrasound.
Right, as correctly said. So if we have a diagrammatic representation like previous diagram we have seen, we can explain or we can counsel the patient about if the fibroid is having location nearby the cornu. So we can counsel the patient prior surgery that your fallopian tube can be damaged, and that can result into, you will not be able to conceive through that fallopian tube. Second point is we can prepare ourselves for the difficulty during surgery. Like if it's a posterior wall cervical fibroid, then we have to really buckle our shoes, and I mean, we have to be ready for the difficult suturing particularly. Okay. So Dr. Shrikant sir, can you please highlight about the trocar entries?
So for fibroids, we generally make the optical trocar, we generally make it above the umbilicus, because the concept is like with myomectomy, for the fibroid always rises, it comes towards yourself. So your port should be in such a way that your instruments and your telescope have the space to move around inside the cavity. So we make the optical port, which is 3-4 centimeter above the umbilicus, and one and two ports on the left side, and one port on the right side. We generally make so total 4 ports. Three are 5 millimeter, and one optical, which is 10 millimeter port.
Yes. And
Yeah,
I
just
think
to add on, I just wanted to add on
yes,
one more point. Like the bigger fibroids, I always go for the lateral approach. So I put the secondary port first, and under vision, I decide how much highest I can put my optical port. So this really gives you know, when you operate with the big fibroids, it gives a sort of visual shrinkage. So if you are at the very highest position, of course, you have to avoid injuring to the falciparum ligament, and sometimes the bleeder are there, but in the lowermost portion of the falciparum ligament is quite bloodless. So you go ahead and under vision, you put your optical trocar. It could be at the Lee Huang point. It could be, maybe it is higher, or maybe it is little lateral, but you put it under vision. That is the point. So that you can put the highest point, and then you can have all advantage of visual shrinkage, and during surgery also you feel very comfortable.
yes, agreed, madam. But whenever we are dealing with large masses, we have to shift our trocars, I mean, towards the ZP sternum. And in that case, we have to take care that we should ask the anesthetist to deflate the stomach by inserting Ryle's tube.
Yeah, that's very important. Yeah.
Yeah. So regarding now taking the incisions on the uterus, so Dr. Varsha, madam, can you please elaborate about I mean, which incision you will prefer, whether vertical or transverse or oblique or elliptical?
Sir, I do the laparoscopic cases with contralateral suturing, so I prefer oblique incisions on the fibroids. And in case of cervical fibroids, we can go ahead with vertical incisions, as if we take oblique or horizontal incision, we can tear the uterine arteries over there. So we have better to separate the bladder and go ahead with vertical incision in case of anterior cervical fibroids. In case of broad ligament fibroids, we have to see where the maximum bulge is. Depending upon that, we have to take either anterior or lateral or posterior incision in case of broad ligament fibroids. And when sorry, there are posterior cervical fibroids, there are generally, it is very difficult for suturing whichever incision you take, but preferably we take a horizontal incision. And if it is not possible for us to suture from above or laparoscopically, we can go from below, and we can suture the cervix vaginally. We also have that option there, because many of the time it is very difficult to suture when it is deep seated posterior fibroid. In case of other fibroids like fundal and everything, oblique is better. Whether you do contralateral or ipsilateral suturing, oblique, I think oblique is better, because we don't go either. If we take horizontal, we can go to the fallopian tubes and damage the tubes, and it is better to take a oblique incision, sir.
Okay. Any of the panelists prefer midline vertical? I mean,
I just wanted to add on, like the fibroids are small. As Dr. Varsha said, I also try to go oblique incisions. But when the fibroid size is big, so then whenever we are operating fibroids, always take panoramic view and go toward the base, because sometimes you try to give oblique incision vertical and longitudinal, and it's broad base fibroid. So then you understand the broad base fibroids are very easy to remove, just to give incision all around the fibroid at the base. So take that panoramic view and go toward the base of the fibroid. And for big fundal fibroids or any lateral wall fibroid, what I always give the circumferential incision or elliptical incision. So always leave some tissue which you have to calculate at the time of the surgery. You leave some uterine serosa so that you can suture it. When you suture the myoma base, so there should not be any tension at the suture line. So you have to leave enough tissue while for the suturing, and rest of the tissue, I think you can remove. Your myomectomy are going to be very easy if you give elliptical incisions for the big fibroids.
It's because, as rightly said, big fibroids, myometrium is very much stretched. So even if we take an elliptical incision, we are not going to lose much of the myometrial tissue. Dr. Shashank sir, do you agree with, are you suturing, you suture ipsilaterally or contralaterally? And which incision you are comfortable with?
So I agree of what has been said about choice of incision, the direction. I just want to add that, primarily the decision regarding the line of incision, it depends on your ability to how you're comfortable doing it. If you're a ipsilateral surgeon, I'm sure we would prefer a transverse or a oblique. If you're good enough in contralateral suturing and it demands, then you can give a vertical one. So primarily it is your ease of suturing, your dexterity, your being ipsilateral or contralateral. That should decide how to place. And then, of course, there are situations where there are, I'm talking about routine situations. As ma'am said, elliptical or circumferential at the base. If it is subserous, it's protruding too much outside, definitely you can give a circumferential incision. But I think even in that, you would labor a lot. You have to give a large circumferential incision. If you give same way, if you give at the top, the broadest diameter, and it will just pop out. So I don't know. It depends on your experience.
Right.
May I just add, sir?
Yeah, please.
Yeah, thank you very much, sir. I was just checking my mic too. The other thing that is there is that it is better to take a slightly bigger incision if required, rather than struggling at the end to suture and remove it with a smaller incision. Sometimes people have a habit to take a smaller incision and then to remove that myoma, and then they struggle to fix up the base very well. So the suturing at the base is not done well, and that is the reason for a bad scar. So it is easier and safer to take a bigger incision even for a smaller fibroid. Don't compromise on the incision. The second thing is the position. Already discussed the ipsilateral or contralateral. See to it that your TV, the camera, your standing, your incision, everything is in straight line as you doing for an open surgery. So if you can mimic that open surgical thing, then if everything is in straight line, then your ease of suturing is very faster. Wherever it is possible, there may be places wherein it may not be possible, but just think over it. If it is possible, see to it that the incision is in the line wherein the suturing is very easy. Thank you.
Right. So midline vertical incision is difficult if you are suturing on by ipsilateral technique, but on contralateral it can be done. So let's move on with the blood loss during surgery. So I don't think if we are dealing with large masses, then GnRH is of any help. Apart from that, doctors, Saubhagya sir, please can you elaborate about the uterine artery ligation or internal artery ligation to prevent the blood loss during when you're dealing with the large myoma particularly?
I personally don't have any experience in relation to internal iliac artery ligation during myomectomy. Yes, I do have experience of uterine artery, tackling uterine artery at the origin, and preferably I took it bilaterally. And I think there was a nice discussion, demonstration in this previous speaker, how to do it, what is do's and don'ts. And yes, that is that take proper care. And depending here is one practical tips is more important is your team actually, cameraman and your assistant actually, when you are starting doing the surgery fast your team is more important and while you are going to tackle the uterine artery from its origin. Take care of ureter, take care of large vessels, identify because there are nice points how to identify the vessels, equally tortuous vessels, bluish hue, starting coming from the laterally to medial side. But be sure before whatever the technique, whether you are putting a clip, you are just coagulating or you are putting a shoeless suture also, be sure to identify the vessel first.
Yes. So, Dr. Shrikant sir, please tell the audience about use of vasopressor. I mean, the vasopressin injection.
Vasopressin, we use like 20 units in 200 ml of normal saline.
Yes.
So before injecting into the fibroid, we always inform the anesthetist that we are injecting the vasopressin, and we inject till the blanching of the uterus is seen. And again, after the blanch, the blanching effect, the vasopressin effect will last for maximum 20 to 30 minutes. So yeah, so we try to do the surgery. We try to enucleate the myoma within that time, and yeah.
Right. So as we know, blood supply through the blood supply of fibroid area is through the normal myometrium. So I always prefer injecting the vasopressin into normal healthy myometrium. Rather, we need to avoid injecting at the base of the fibroid. Many people do the mistake, and that will result into intravascular injection of this thing. Dr. Kalyan sir, can you please take forward?
Yeah. So we have discussed about the myomectomy, steps of myomectomy, what is the how to decrease the blood loss, what is the shoelace technique, everything is been discussed. Now, what are the challenging situation, Dr. Shriram, you find whenever you have a report of a broad ligament fibroid or a cervical fibroid? What comes into your mind? What is the planning going on in your mind before starting the surgery?
I generally prefer to do the sonographies myself, even if I do have a report from outside. I just had a case wherein this particular fibroid that was there, she had come in and this particular fibroid was highly calcified. And I can post this particular video after the session in the group. This particular thing was so calcified that you can't even morcellate it. I had told that the morcellator blade would break. So it is wiser in such a case to open it and possibly remove it. Even cutting it sharp was very difficult. So firstly, we should know whenever we are doing, we should know about the location of that particular fibroid, whether it is a broad, whether it is extending, it is an unusual location, it is compressing on the ureter, whether the ureters are dilated or not. If it is cervical, it may be difficult to say whether it is exactly posterior or lateral, because sometimes we may have a combined view. Intra-op decision comes into the play. As already mentioned over here, we need to know whether she's previously operated, adhesions are expected, single fibroid, multiple fibroids. See to it that you remove as many fibroids as possible with a single incision. That should be one of the plans that should go. So fibroid mapping should be very well done. So we should know pre-op itself with regard to how we are planning to remove these particular fibroids.
Okay, that is rightly said. A proper planning team should be ready. You should see about the morcellator is working or not. You should counsel the patient about the endobag and all its effects. And Dr. Saubhagya, what is your take on cervical fibroid? How do you take an incision? If it's a central, lateral, how do you decide? Cervical fibroid.
Cervical fibroid. Okay. I personally prefer that is to see what is the majority location actually, whether the bulge is posteriorly or bulge is interiorly. But I usually take posterior approach. Posteriorly I go and I prefer to give because I am also ipsilateral surgeon, posteriorly give either an oblique or a transverse incision and try to enucleate it is properly. Taking care that ureters actually, if it is extending, to find out that it is ureters are not coming to the operative field and other vital structures are not injured. I usually take a posterior approach.
You take posterior approach. Okay, so first you dissect uterine artery, see the ureter, lateralize it and go, or directly take an incision?
No, no. But taking the proper care actually. Because if it is a large one, to control the bleeding, take the uterine artery, see the course, at least see the course of this ureter, then I go to give the incision.
Rightly said. You have to be very judicious about the ureter. You can injure the ureter here. You have to be rightly taking uterine artery if it's a very big fibroid. But that is the case is different with the broad ligament fibroid. Dr. Shrikant, how do you manage a broad ligament fibroid? What is your principles?
Exactly the same thing for the broad ligament. We see exactly where it is, location, and for broad ligament, I go anteriorly mostly. And sometimes, like in cervical and broad ligament, also it is if the fibroid is very large or you're not able, then in that case, you are not able to reach the uterine artery only. So in that case, we do not do the uterine artery temporary ligation. We just go for with the vasopressin. We try to inject in the broad ligament. Again, the vasopressin also get dissipates at some places. So again, we just go in front of the round ligament and we try to remove it from there. Like the
So
anterior.
open the round ligament every time, right? If it is a big fibroid.
If it is a big fibroid.
Okay, broad ligament fibroid is very important to have a effect like traction and counter traction. That is the only principle in broad ligament fibroid where you're going to easily remove it. Again, you have to see for the uterine artery, you're going to see for the ureter, though it is very rare to have ureteric injury if you go anteriorly, but you have to be very cautious about this. Then afterwards, once you are done the medial part where if there is any bleeding, you have to suture it back. Then round ligament suturing is there. How many of you put a drain after the surgery of broad ligament myomectomy?
I always put it.
Yes, Dr. Usha Kumar, can you just
Yeah, I just wanted to add on in the cervical fibroid, if it is anterior cervical fibroid, it's always a good idea to dissect the UV fold and push the bladder down. It automatically push down the ureter and you are away from the danger. Number two, go for the oblique incision. That also helps because at the time of extraction of fibroid, you happen to have your incision is getting extended. So it is not involving to the uterine arteries in that case, number two. Number three is, for the broad ligament fibroid, one more thing I wanted to tell you. I always use 10 units of vasopressin in 400 ml of saline. So this is the 4-time dilution, and I go with the injecting around 200 to 250 ml of this solution in the around in the base of the fibroid. So it not only gives you very good hemostasis, but it also gives you very good for the extraction of fibroid because it's doing like something like hydrodissection. So this is very beautiful. Third is for the broad ligament fibroid. I give incision on the most prominent part of the fibroid. And if you use 2 myoma screws, like walk over the fibroid, I always ask my assistant to hold 1 myoma screw and one I hold it in my left hand. And then you do the traction and counter traction. So it comes out so easily and very nicely. And I always like to peritonize the tissue to close the base because in that case, the possibility of your bowel is going to stuck to the raw area is really getting minimized. And I always love to put the drain, So what happens, whatever level of peritonization, whatever level of hemostasis you maintain, there is a little bit of oozing from the myoma bed. So that if you leave that amount of fluid, which is blood stain, that is a good culture media for the bacteria. So it's always a good idea to put the drain. And as I said, I always run, if I'm not using vasopressin, I give oxytocin, and that also gives very good, it put the uterus at the contraction at the time of surgery. So there's hardly any blood loss. And if you use oxytocin, you will also see in your post-op, there's hardly any fluid in your drain. So that really works miraculously.
Very good take-home messages given by Dr. Usha Kumar. Dr. Saubhagi, you want to add your experience about the broad ligament fibroids?
My response was in relation to that question whether you put the drain or not. So I agree with Dr. Usha Kumar. There will be capillary bleedings in broad ligament fibroid, and how meticulously you close the peritoneum also, there is chance of a potential space there. So there is a chance of collection. So my take is usually I prefer to give a drain for broad ligament. That was my response.
Dr. Varsha, you want to add something?
Yes, sir. So basically, when we remove the intramural fibroids, their blood supply will be more than the broad ligament fibroids, because broad ligament fibroids are generally wrapped in peritoneal reflections. So if we close the cavity meticulously and watch for hemostasis then and there, then I don't think there is any need for putting a drain.
Okay, but preferably take-home message is always better to put a drain. It is safe because at 5 mm port you are going to put this drain.
Okay.
Now, Dr. Shrikant, this is a case of 24 weeks fibroid. Can you just give us some tips of incision, how you are going to take? What are your tips and tricks while doing these large fibroids myomectomies?
Again, with large fibroid, once we are inside the cavity, we again need to see the anatomy. So anatomy, we can see with the position of the fallopian tubes. So accordingly, if the for the fundal fibroids, there's a big fibroid, I generally give the vertical incision. So because again, for suturing, it becomes easy, and there is if we have to again extend the incision, we do not go towards the fallopian tube. We can go anteriorly and posteriorly. So that's why I give the vertical incision for the big fundal fibroids. And yeah,
your tips for doing a suturing, because here you can see a lot of bleeding is coming because it's a large fibroid. We are taking something called as box stitches.
We also take the box stitches with Vicryl number 1. So after taking the box stitches, then we close the upper layer with maybe starter fix or V-lock. But yeah, we take the Vicryl box suture for the big fibroid, for the big tissues with Vicryl.
Okay, so what is the suture material you use for suturing of these myomas?
So for inside we use the Vicryl, and outside we use the PDS or this starter fix or V-lock sutures.
What are these barb sutures, and how advantageous you find in using barb over the Vicryl?
The barb sutures are basically PDS suture, and they are delayed absorbable, and they give strength, and they do not have to exactly take the we do not have to tie them because they do not go back, and are delayed absorbable. So yeah, they are easy for they make surgery fast because we do not have to we do not have to tie them every time. So they just make the surgery faster, and so sometimes it's not necessary we interchange, because we do not. It's not like we have to use the barb suture. We can use Vicryl also for the outer layer. Yeah.
Yeah, there is always a reduced blood loss, a decreased operative time, and good closure. And importantly, a dead space formation is less whenever you are doing this tightly suturing.
There is uniform pressure tension at the suture line because of the barb sutures.
Very rightly said, Dr. Basha. So these are monofilament absorbable suture. They make the suture grip the tissue without any suture to slip back to become loose. Barbs allow suture to be pulled in one direction. Suture cannot be pulled back in the reverse direction to follow the suture material to hold it tight. Continuous suturing becomes very easy, and no need to tie a knot in the end. So that are the advantages. And self anchors at approximately every 1 millimeter of the tissue, and uniform distribution of wound tension across the suture than conventional running smooth sutures, and more consistent in the wound apposition. So continuous interrupted suture without all the knots, that is the advantages. And the is right. Who's this? Yeah. You want to add?
One thing, yeah. I think as far as box suture is concerned, it is a very good suture. You know, you can take care of the bleeding, but you should not overly rely on just box suture. If you have, like I was seeing the video, there was a lot of blood loss over there. I think one should clear the field, and if there is a sputter, if there is a bleeder, that should be dealt separately. Otherwise, I have my own of dealing with the, I just took 2 box sutures in a large, more than 24-week size. And then it kept on bleeding because I did not deal with that particular bleeder. So one should clean the field. If there is any sputter oozer, you should deal with it. If there is a generalized ooze, of course, it's a good one, quick one, you will have hemostasis. Second point is regarding barb suture. I believe it's an error. It's not that costly. It's just 3,000 rupees. In the long term, if you look, you yourself enumerated, there is a meta-analysis. The evidence is out. With barb suture, it takes less time to suture. The blood loss is less, the hemoglobin drop is less. But the most important thing, it is the tissue healing. The wound healing is far better because of that even distribution of tension across the length of suture rather than just at the knot. Because of these barbs which are put at 1 millimeter distance, so they self-anchor. So it is the wound healing which is best. Hemostasis, approximation, everything is good with. Only concern would be if you are using the barbs at the seromuscular layer, at this, when you're approximating the edges, and then there is a possibility of adhesion formation. Well, you can always put a adhesion barrier, or you can just use, I think, the baseball sutures that will invert the edges, and the suture line will not be exposed. But
Yeah.
for instance, barbs I think they're cost effective in the long run.
Dr.
Reduce.
Shashank, just to add on this thing, what I do, I always use barb suture at the base of my in my first layer, and
Exactly.
then
That's what I said.
if you use baseball suture, then there is a less exposure of the barb on the surface of the uterus, and there is a less possibility of bowel adhesion and subacute intestinal obstruction. Because this I have seen. When I was using barb suture for the second layer closer, then there was a lot of exposure of the barb tissue on the surface. And 3 of my patients in few years back, they came back with the subacute intestinal obstruction. So
Ma'am, number one reason for the reason or the mechanism they say for the subacute or acute intestinal obstruction is when you leave a stump of the barb.
Yeah.
So when you cut the suture, it should be cut flush with the tissue. When you leave a part, it stays like this, and then the bowel will come and the mesentery gets hooked up. They say that's the mechanism. That's how it happens.
Yeah,
So
right.
wherever you use barb suture, cut it flushed.
Good idea is to use barb suture for the first layer and use if you are using for the second layer, use baseball suture. It's really approximate the tissue very nicely.
Yeah, I agree, totally agree.
Yeah.
I think Dr. Kalyan has left.
Am I audible? Yes.
Yeah.
So as Dr. Shashank sir rightly said, we have to keep we have to take one extra bite and cut with the flesh. So we are not worried about the slippage or the getting loose. So regarding the previous case where Dr. Shashank sir said there was a lot of bleeding, but if that was my case actually. In that patient, I did internal iliac ligation because it was a big mass, even though there was a bleeding. So after doing, I spent couple of minutes to visualize any particular bleeder, but there was a lot of bleeding. So I directly went in with the 2 box stitches. Area was more. And eventually that reduced bleeding. Later on, we continued with the barb stitches. Yeah. So regarding, as you said, adhesion barrier, interseed, many of us must be using. Anybody differs on the use of adhesion barrier?
Interseed is very good, and if interseed is not available, you just put a small piece of Surgicel over there just to cover your suture line. That also helps to prevent the.
What I do is, if it is not available, most important thing is to have hemostasis. Actually, it is the clot which is the reason for adhesion formation. But as ma'am said, Surgicel will also.
Yes.
Nowadays, there is no role for interseed actually. There are papers suggesting that interseed will not cause adhesion, means they will not prevent adhesion formation.
I don't know. Evidence will keep, following that whole circle. One day they say there's no role, then others.
Basically, those people who were using interseed before, they are not using it nowadays.
Is it a level 1 evidence? How do you think the evidence, how good the evidence is?
No. Basically, those surgeons who were using interseed beforehand, nowadays they have stopped using interseed. Absolutely. So
But
it,
as of now, the evidence is suggestive, is in favor of prevention of adhesion after using the
yes,
cellulose or interseed material. So I think till we get the, like Dr. Shashank sir was saying, till we get the sufficient evidence, so let's use it. Or else alternative is mental patch. It's a very easy and natural
yes,
adhesion
yes.
barrier, so we can use it. Dr. Sriram sir, are you there?
Yes, yes, sir.
Can you please add on to the adhesion barrier?
Yeah, you should use adhesion barrier. That is a take-home message.
Okay.
Nothing to add on.
Okay. I think Dr. Kalyan sir is not able to join back
Sir is joining back, sir, within a while.
within a while. Okay, okay,
Yeah.
fine.
He's trying to join.
Okay.
He's already joined, I suppose. Kalyan, sir.
And hemostasis is very important whenever we are using interseed or cellulose.
Yeah.
Because if there is blood, it won't work.
It doesn't work.
Yes.
He is back. Dr. Kalyan is here.
Kalyan, sir. Can't see him.
Your screen is being seen, but you are not audible, sir.
Yeah, now I'm audible. So
Yes,
sorry.
Yeah, we can see you,
There
sir.
is a range going on here, so it was unstable. So now we have talked about the adhesion barrier. So now we come to two cases, last 10 minutes. So this case is 26-year-old lady, primary infertility for 2 years, normal semen parameters, normal ovarian reserve, ovarian function is normal, HSG showing bilateral tubal patency with suspicion of 1 centimeter submucosal fibroid. So, Dr. Sriram, what are your take home on this?
The take home is this particular patient is having infertility, and we already know that there is a suspicion of a 1 centimeter fibroid. So go ahead and do a hysteroscopic myomectomy for her. As already suggested,
we have
do a
discussed
good
this.
sonography before that, and see to it that you have grade 0 or grade 1 fibroid. One thing that was missed in the discussion that was there previously is that whenever you are doing a hysteroscopic myomectomy, see to it that you don't use a very high pressure, because in that case that particular fibroid goes inside the uterine musculature. So you should be aware when you should decrease the pressure so that you make a grade 2 or a grade 1 into a grade 0 so that you get it inside the cavity. So sometimes you have a reporting that it is on ultrasound that it is a submucous fibroid, and when you put inside you don't see that because because of the pressure it goes inside the myometrium. That was one point. That's all.
Yeah, we have discussed this case thoroughly. Dr. Usha ma'am, this for you, 33-year-old lady, primary infertility for 1 year, normal ovarian reserve, oligospermia, bilateral patent tubes, TVS is showing 4 centimeter asymptomatic intramural fibroid. How do you go about this?
Okay. So I would like this patient to go and consult urologists for the correction of oligozoospermia. That's very, very important. And second thing, 4 centimeter of fibroid. So infertility is also one of the symptoms of the fibroid. So it's symptomatic. So I would like to go ahead with the removal of fibroid as well. At the same time, assessment again, I will plan the diagnostic hysteroscopy also again for the see and treat approach. So laparoscopic myomectomy, referring to her to the urologist for oligospermia correction, and to diagnostic hysteroscopy to rule out anything associated, because she's already 33 years old.
And
So,
Dr. Saubhagya doesn't seem to be convinced with this. What is your view, Dr. Saubhagya Jaina?
My view is to tackle the male factor part,
yeah.
as he is asymptomatic and we are getting a factor for infertility and no other symptoms for fibroid. I don't think I will go for a myomectomy in this case. So my option is
Shashank,
not
what is
to.
your view?
I would also agree. I want to say that, see, fibroids are the most common, the reported incidence is 30%, but that's in those cases who report with symptom. If you go about doing ultrasound in community setting, they say the incidence in reproductive age women would be around 75%. 75% women will be picked up if you go about indiscriminately doing ultrasound and picking up incidental fibroid. This is a case of incidental fibroid, I would say. So I think oligospermia should be treated. After all, surgery is a invasive procedure. It has its cost, it has its, complication rate, even in the best hands. So I think first oligospermia should be treated. A 4 centimeter intramural fibroid may not be the reason over here. We might be doing over treatment. If that doesn't help, when we treat the male factor or howsoever we treat it, then we can attribute the cause that the fibroid also may be contributing to the infertility.
Dr. Varsha, what is your view? Unmute, please, Dr. Varsha.
Sir, I will go for laparoscopic myomectomy till the suture line heals. Till that time we have for treating the oligospermia also. So
you got 3 months time to treat oligospermia. By that time, you are going to do a myomectomy. Dr.
Yes.
Shriram, what is your view?
I will operate on this case, sir.
Okay, so whenever there is a controversy, experts come in through role. Dr. Bhaskar, sir, you are there, I suppose. Dr. Bhaskar, sir?
Yes, I am there.
So what is your view about such case where asymptomatic intramural fibroid not indenting the cavity and
Do not touch.
do not touch it?
If she's trying to have a baby, do not touch. If you're planning to do IUI, do not touch. If you're planning to do IVF, it's a very difficult situation. Under 3 centimeter, don't touch. Beyond 5, do a myomectomy. 3 to 5, do a trial IVF cycle. If it fails, then do a myomectomy. I think the evidence is very clear cut on this.
Yes, so we are not going to touch this fibroid. Now comes the third case where all parameters are like this and TVS is showing asymptomatic 4 centimeter intramural fibroid slightly impinging in the cavity with normal semen parameters with HSG showing bilateral tubal obstruction. So Dr. Varsha now or Dr. Usha ma'am, you can take this.
Again, for this patient,
yeah,
definitely I will plan. She's already 37 years old, so she's already late to conceive. So I will plan laparoscopic fimbrioplasty, or depending on the site of the obstruction, hysteroscopic annulation or laparoscopic fimbrioplasty, depending which site the obstruction is there. At the same time, it's a good idea to remove the intramural fibroid as well. So laparoscopic myomectomy plus fimbrioplasty or hysteroscopic annulation for her.
Anybody differs now here? Dr. Saubhagya?
I agree. I will go for myomectomy also in this.
Right. Myomectomy with correction of the tubal occlusion. If tubes are not open, then she's a case for IVF. As Dr. Prerna, you want to add something, I suppose. Dr. Prerna? No? Okay, so how many of you are going to do endometrial integrity test or something like that after the myomectomy? Dr. Usha ma'am, you do it?
Oh, endometrial integrity test, actually, again to say, as I said, it's not required because you are not bothered about whether endometrial cavity, your management is not going to change whether the endometrial cavity has been opened or not. So earlier they used to close the cavity, but nowadays we are not closing the cavity. But you should not, while closing, when you suture the base of myoma, you should not go through the endometrial lining. That care should be taken because it may be the site for adhesion formation. So better not to suture your endometrial cavity. It should not come into the endometrial lining. It should not come into your suture.
So no need of doing any methylene blue test. Now over to Dr. Balaji Nalwar, who is going to take the morcellation part.
Thank you, sir. Sir, as Bhaskar sir has very clearly said, there should be no naked morcellation, and this is sometimes even we do for small fibroids like 1 or 2 centimeter, 3 centimeter. We think that we can take it out. But sir was very clear that in not only we are worried about the sarcoma, but the spillage. And if you see this video at the end of this, when we took out the specimen through the 10 millimeter trocar, you can see small pieces of the myoma. They are lying there. And sir was talking exactly about the same. If we do this, there is a possibility that we can land up with the wandering fibroids like. So for that, and it is not a very difficult for use the endobag because they are very surgeon friendly, I can say. Only thing is we have to understand how to use it. Sir has very nicely shown the how to load the bag. Then with the trocar, same trocar we can introduce into this. The problem comes at this point when to, I mean, how to feed the tail end. So if we are having one more extra port on the right side. Through that port, if we railroad the through that, it is the best. Or else, what we can do, we can put a 5 millimeter. We have 4 millimeter telescope. Everyone being a gynec surgeon, so we use that for hysteroscope through the left upper port, and under vision you can directly take the tail through the primary trocar. And once you are in the, once you have placed the fibroids inside the bag, then just take out to the left lower port, I prefer. But we can use any of the port like supraumbilical port also. And after distending the bag, we can easily do the morcellation. And the two important things that are very that we can notice when we are doing endobag morcellation, that we don't have to worry about when we are picking up the small pieces that are left behind. We don't have to worry about the injury of the underlying bowel or omentum. And we don't have to waste the time, particularly when we are tired after doing a big, after removing big myoma, giving a wash and finding out all the small particles like that. And here also sometimes we see the difficulty if we don't pull the bag properly out from the lower port, then there may be some rotation and you can encounter with difficulty while passing this. So for this, we simply we have to enlarge the port before putting the bag 1.5 centimeter, and also most important is rectus. We have to cut the rectus to prevent all these sort of problems. And at the end, when we take out the trocar, the camera, just tie the knot and just pull out from the lower port. That's the end of the story. I mean, we should, once we start using, initially, I was also feeling quite difficulty, getting difficulty while using this, but once you are used to it, it's very easy thing to do it.
So, very rightly said by Dr. Bhaskar sir and Dr. Balaji. This is one of the case which I got it from Dr. Minu Agrawal. This is myometrial scar ectopic. So what is your, anybody has ever encountered such cases of any myometrial scar ectopic? You can see the video. How to tackle such cases? Dr. Balaji, you can take this.
Vasopressor, vasopressin injection will be the best, and we take purse stitch all around. If first we need to evaluate if we can manage it by methotrexate, and if it's a live pregnancy and if it's not fitting into the criteria, then we can directly go with laparoscopic excision. Here, if we go ahead with laparoscopic excision, because it will prevent, if we go by laparoscopy, it will prevent subsequent recurrence of the repeat implantation into the same site. So that's the advantage of laparoscopy. And at the same time, we can excise this defect also.
So this is very rare complication, which you can see the live pregnancy also.
So to prevent this, we have to concentrate on two layers: subendometrial approximation of the tissue and the serosa. If we concentrate on these two layers, middle ka to ho hi jata hai automatic.
Dr. Kalyan, I have a question. Now we're saying it's a myomectomy scar ectopic. Why can't it be a cornual pregnancy?
This patient actually is not fine, this patient gives history of doing a myomectomy 3 months back, and this patient presented, and as you can see the location, it is not at the level of cornu, it is more on the medial aspect, and we have to open the round ligament to remove this, so it fulfills the criteria of the myometrial scar ectopic. Anybody wants to add, because I have never seen such case?
I have never come across, yet I have reported a case of cornual. I have reported 2 cases of cornual pregnancy as in very early career of my very early when I was a resident. So no, I have not heard about it. So that's, I mean, for me, it's a new entity. That's why I asked.
Really, for me also, it's a new entity. Just to complete the panel, I have taken from Dr. Minu Agrawal.
It must have been.
Yes, Dr. Varsha.
I have seen such a case in one conference of Sunrise Hospital, sir, where they have shown such case where there was a post-myomectomy scar ectopic pregnancy, but they have conserved the pregnancy and they put the mesh over the this bulge coming out, and they put the mesh and they continued the pregnancy till 36 weeks, and then they did the cesarean section. It's
okay.
Not on the scar ectopic.
That was scar ectopic, I think.
That was myomectomy scar ectopic only.
No,
But
I think no, that I'm not sure.
Cesarean scar or myomectomy scar ectopic?
Myomectomy scar it was.
Okay, so I think what she's talking about, yes, and there's a case which Sunrise Hospital showed. That was a
Yes.
myometrial pregnancy in the fundus, which they treated and let the pregnancy
Yes.
continue, and the pregnancy continued, and they did a cesarean at 36 weeks.
Yeah.
Yes.
Right. So now coming to the end of the part, tips of myomectomy: single anterior midline vertical incision as far as possible, minimal multiple incisions. Incisions should extend through serosa, myometrium, and into the capsule of the myoma. Size of myoma should be less than 10 centimeter in lap myomectomy. As per everybody's experience, you can do a bigger also. The intermittent use of vasopressin is effective in reducing the blood loss. Suturing using barb suture is less time consuming. Creating less of myomas by passing a thread through each myoma prevents losing them in abdominal cavity, and creating garland of myomas by tying two free ends of the lace helps in easier bagging. Morcellation in bag prevents dissemination of bits of myoma and even injuries. So to conclude, preconception lap myomectomy in indicated cases has a better pregnancy outcome. Surgical expertise is a key factor in optimizing the results, and pre-op mapping of fibroid plays a crucial role in precise surgical management. I thank Dr. Bhaskar Pal sir for giving us this opportunity, to me and Dr. Balaji for taking this panel. I thank Dr. Saubhagya, Dr. Usha Kumar ma'am, Dr. Shashank, Dr. Varsha Patil, Dr. Sriram Iyer for having such interactive session of panel for lap myomectomy tips and tricks. Over to Dr. Balaji.
Just to add on one more thing.
Yes, ma'am.
My practice has been changed nowadays. I mean, I shifted from laparoscopy to robotic surgeries. Now 60 surgeries are over. I have done all difficult cases of myomectomy with robo. It's Da Vinci Xi system, and it's working beautifully. I mean, you will be surprised. I have uploaded my videos also on Google, and then it's on YouTube. You can see it. So beautiful myomectomies with robo. And suturing is so easy, and we people are using this COVIDian bag for, we are not using this Morset bag, we are using COVIDian bag. You just have to put all your myomas into the bag, and then you can do morcellation. So it's working so beautifully. Just wanted to share with
Thank
all
you, ma'am.
Thank you, madam. Thank you all the panelists, and I must thank the organizers for inviting and giving this opportunity. I thank Dr. Kalyan sir. He has taken all the pain and prepared the presentation. And I must thank Dr. Bhaskar sir for inviting and giving this wonderful opportunity. And I wish all the best, sir. You are there. Just now the only, I think the formalities are remaining. So best wishes, sir.
Thank you everyone for your
Best
time.
wishes, sir.
Yeah, we keep saying that the endoscopy attracts the highest audience. These days, it's got very, very difficult to get a good live audience. But I know we have crossed 1,000 today. I don't know what is the final figure. I'll let you all know in the group when we get to know.
Thank you, sir.
Yeah.
Thank you, Kalyan sir. Thank you, Balaji sir.
Thank you. I thank Dr. Prerna Keshan for this opportunity.
Thank you so much
And
to
we
the
wish
moderators.
Dr. Bhaskar Pal sir for his upcoming election. Please motivate people to vote for Dr. Bhaskar Pal sir. He's a true leader.
Yeah, thank you
And
so
as I
much,
said,
Dr.
vote.
Bhaskar, for inviting me
Most
for
important
this
thing is to
panel.
vote.
Yes.
All the best.
Wish you all the best, Bhaskar sir.
Best of luck, sir.
Thank you, Dr. Balaji. Thank you, Dr. Kalyan sir, for a wonderful and a very interactive session. Thank you all the panelists for your inputs. And as we all know, all good things have to come to a conclusion. and is, however, customary to express our heartfelt gratitude to one and all who have joined in today for making this web meet a success. I thank Dr. Bhaskar Pal sir at the very outset, who is the reason why we all are here, why we all could have this series of cohesive, intensive laparoscopic academic feast, we can say. I thank all my co-conveners and our national coordinators and our guests of honor for today, our chairpersons, speakers, moderators, panelists, and all the tech partners and the academic partner, and all the delegates who have chipped in today. And thank you all for this wonderful, wonderful meet. And till then, we meet next time. Have a pleasant evening. Thank you,
And we have the final figures. It's 1150 today.
Great.
Great.
Thank you so much.
Counting.
Everyone.